Morning and welcome. I'm Burton Melnick, chair of this wonderful National Forum for Heart Disease and Stroke Prevention. I am pleased to welcome you to the 2025 annual meeting. When I became the National Forum chair, my goal was to elevate heart disease and stroke prevention, as 80% of cardiovascular disease and other chronic conditions are totally preventable with just a few healthy lifestyle behaviors. Today's meeting, championing a heart-healthy America, uniting against the leading cause of death, speaks directly to that goal. As you know, cardiovascular disease is the leading cause of death in the United States, despite outspending peer nations by more than double per capita on healthcare. The United States ranks last in life expectancy among high-income countries and suffers higher rates of obesity, heart disease, and diabetes. This annual meeting, our 23rd, brings together change makers from multiple sectors to improve heart health and close the U.S. life expectancy gap by spotlighting strategies, ones that are evidence-based, to prevent cardiovascular and metabolic disease across the lifespan. We will explore how targeted interventions can create significant positive changes. Today, let us unite to build a heart-healthy America where people throughout society live and enjoy heart-healthy, stroke-free lives. Here are a few ways to help you maximize your engagement and takeaways from today's meeting. Please use the chat function to comment on the meeting topic, panel discussions, and share information. Helpful tips and links will also be included in the chat. Use the resource feature to access the program book with the agenda, speaker bios, and more. Use the Q&A feature to ask questions at any time during our meeting. Following each session, we will have a Q&A opportunity during which our panelists will respond to as many questions as time allows. When sharing key points from our meeting on social media, please blast social media of this event. Please use the hashtag #NF2025. Panelists' X or Twitter handles will appear on screen and are in the program book. Closed captioning is available. You control how it appears on your screen by using the CC button on Zoom. Today's meeting is being recorded and will be available on demand next month. The National Forum will send you the link. Thank you to our sponsors who have made this convening and your no charge participation possible. Toward the end of the meeting, National Forum voting members will elect Board of Directors members and take part in a brief business meeting. And the forum will present awards to individuals and organizations who have made exceptional contributions. I am now absolutely delighted to introduce the Honorable Mehmet Oz, the Administrator of the Centers for Medicare and Medicaid Services, to give our keynote address on making America heart healthy, a vision for bold preventive action. Dr. Oz's biographical sketch is in our program book. As CMS administrator, he leads the largest payer for healthcare services in the United States. The agency's decisions affect more than 4 in 10 Americans' access to healthcare.
Bernadette Melnick. Can't say no to her, and she was kind to invite me to kick off this year's National Forum Conference, focusing on heart health and disease prevention, two things that I am passionate about. We've been talking a lot about at CMS, but they're also important to my medical career, as many of you know. As a heart surgeon, I spent a lot of time trying to deal with metabolic syndrome and all the different processes that culminate in atherosclerosis, which I always felt, interestingly, although we could treat it with coronary bypass surgery and stents, those don't really replace the God-given gift of an open artery. Only changing the corrosive fluid inside of your arteries could do that. And so I would warn patients that I'm going to give you a man-made imitation of what you're born with, but unless you take care of it, it won't remain in the pristine shape that I'll try to restore it to. And because of that, I'm particularly attuned to the issues you'll be talking about over the course of this conference, but it's also become a major focus of CMS. And just to get everyone on the same page, CMS is a Center for Medicare and Medicaid Services. So we provide in social health insurance to our youngest Americans, because roughly 53% of all kids are covered by Medicaid or CHIP. Medicaid, again, insurance for folks who are under the poverty level generally. The CHIP program is for kids whose parents don't have much resources. Elderly folks are covered by Medicaid and Medicare oftentimes if they poor older people, but in average, the 65-year-old and above get Medicare, which is a beautiful social safety net program created 60 years ago this year. And then, of course, there are the Affordable Care Act exchanges that you guys hear about periodically, the Obamacare exchanges. So it allows us to cover a lot of folks. There are so people on commercial health insurance, and no matter where you are in America in terms of your healthcare coverage, you do tend to be wandering down the road to unhealthiness because of the chronic illnesses that we've allowed to prosper in this country. And we'll be talking about the most, popular topic these days, MAHA, Make America Healthy Again, in part because we've made it hard to be healthy in this country, and we want to address that. But I want to take a step back and start off with talking about the role of providers and doctors. We have a responsibility to tell patients what they need to know, even if it's not convenient, right? We're taught to do that. And that same culture plays a role when you're preventing chronic illness and protecting folks against heart health. If we don't tell them that our solutions, the mechanical ones that I spoke of earlier, are going to save their lives forever, we're not doing our job. We've got to warn them that hypertension, strokes, and everything in between are worsened by lifestyle decisions that they're making. Their medications, their devices, but nothing's as good as taking care of yourself, making sure you get daily exercise, eating food that's real, that comes out of the ground, looking the way it looks when you eat it. There's nothing like sleeping well and making peace with the world around you, dealing with the anxiety and depression that otherwise can become quite common. And if you don't deal with those issues, yes, you'll end up with quote unquote essential hypertension, which was always an interesting term to me because there's nothing essential about it. And there's subsequent illnesses that are attributable to it, ranging from strokes and heart attacks to kidney failure and the like. So the uncomfortable truth remains that the same disease that was the number one cause of death in the U.S. when I trained in medical school, cardiovascular disease, remains to be the number one cause of death. But that also gives me hope because there are things we can do to make a difference. That sacred relationship between doctors and patients that we've always had has been stifled. And so we can't actually communicate this important information, I don't feel, as effectively today as we could historically. And I think we need to change that. In fact, what I've started to say is that I'm concerned that a lot of doctors have lost their mojo. We've lost our belief that we are the ballast of society that helps the ship that's traveling into troubled waters weather the storm. So we've got to speak up. And I think patients have also been stifled by a medical system that's rife with fraud, waste, and abuse. So in order to make the system work better, to clean it up, to get it to be more efficient, docs need to get their mojo back. We can't be bogged down by endless paperwork and bureaucracy that keeps us from doing the things that we know we want to do in our lives. And if we get that straight, all of a sudden the bureaucracy starts to melt away and we begin to help patients in their time of need. So let's discuss what this really means. So to me, it starts off with things like patients over paperwork. Right? Are we going to be focused on the computer next to us typing away? Or are we going to actually look at the patient in the eyes, recognize that we've got a covenant, a precious relationship together with them, and nothing's going to get in our way? And if we can begin to move in that direction, then I think we'll have a much healthier healthcare system. Because most of my colleagues in medicine, you guys can attest to this, they don't leave medicine because of the work. They leave medicine because of the busy work. The stuff you're doing that doesn't give you that continuous daily feeling you're making a difference in other people's lives. And amongst those things that we're stuck on are things like coding. I want to mediocritize coding, literally make it irrelevant if you code well or not. Frankly, all that coding predicts maybe 15% of the variation that we see in healthcare expenses the next year. So we can do much better than that. And I'm intent to do just that. Another good example is prior authorization. I don't think it serves the purpose it was designed for. We need some prior authorization, but not thousands and thousands of procedures, and not the way we do it now, where the long arm of insurance protrudes into your exam office, that precious location, sacred location where you're talking to people about something really important to them. And all of a sudden, the patient's being told they can't get that test that tells them if they have cancer. And that's the kind of interaction that's not healthy for anybody in the system. Doctors, patients, the insurance companies have agreed it's not ideal. So we went out to the insurance companies and said, listen, we want to change the prior auth system. We're either going to get Congress to do it. And by the way, I'm in Washington, D.C. right now. I'm looking over this computer at the Capitol building. So I'm very close to where that law could have been passed. So we have plausible ways of doing this within legislative solutions. We also have regulations that CMS can make, rulemaking that can make life very difficult. Or I can come to the insurance industry, which we did with Secretary Kennedy. And President Trump was fully supportive of this, which one of the reasons I love working here is he gives us a lot of autonomy, a lot of freedom to go out and make a difference. Many of us came from the private sector for that reason, for a short stint to make a difference. And so if we're going to play a role in this process, then we need to actually get industry on board. So we said, listen, if you guys are the insurance coverage for 80% of the country plus, which they were, what can you do better? Could you make a gold card? So if a doctor's already doing a great job with their practice and they're not seeing a lot of patients that are being referred erroneously, give them a gold card, freedom to do what they want to do, don't get involved. There are systems that are already doing that, like Highmark, Allegheny in Western Pennsylvania. Or you do what Kaiser's doing, there's no prior authorization. They just tell doctors in timely fashion that they made a mistake, please don't do it again, and here's 5 other ideas you might want to think about doing. And doctors actually want to get better, and we don't repeat the same error over and over again. We didn't get through medical school making lots of mistakes. So that's sort of a high-level example of how we can use the long arm of government in a more effective way with a nimble solution that's fast, efficient, and adjustable. So as prior auth shifts and AI gets better, for example, maybe you don't need any prior authorization at all. And the ability to mediocritize coding, therefore, becomes something that is intricately tied into this new technology that a lot of people are scared about, but can be used for good. For example, many of your practices could be made more efficient if you had access to AI and knew how to use them and it was affordable. You could have MD extenders. Maybe there's some of the things you do in your practice, or any clinician, frankly, could take advantage of that could be absorbed by an AI avatar, and then they hand the patient to you once they've been through this entire process, and you've already gotten all the information that's required to identify some of the reasons they're not doing the things you've been asking them to do. These avatars are remarkably sophisticated. And if you have not played with them, I encourage you to try it out, because they are actually able to tease out subtle reasons why patients aren't doing well that oftentimes in our busy clinical practice we might miss. We can also have AI play a role after they've you've seen the patient and they've gone home. Are they taking advantage of the recommendations you gave? What about if there are blockages you didn't know about, like they can't afford the medications? I mean, some of the things we've been doing with most favored nation drug pricing is going to help, because 1 in 3 patients goes to the drugstore and can't afford their meds. But you still need ways of helping patients do the things you're asking them to do. If they're depressed or they're having a bad day and they decide to ignore your advice on their diabetes, you need to hear about that. Just playing a role, connecting you to the system and making sure they are in touch with you or your office, or at least the system you've designed to help them, would all be beneficial. And all of these, I think, are going to play a role in my organization, because things like Medicare open enrollment, which we're in the middle of now, are much more targeted and effective if we can enhance them by knowledge of what's going on in the patient's life. And AI can help us with that without intruding into the process, again, that special relationship that we have with patients. So let me now conclude with MAHA. I promise you I talk about it. To me, the Make America Healthy Again movement is all about curiosity. Are you truly interested in examining what's happening in the world around us and maybe fixing it, at least addressing some of the shortcomings? And especially in rural America, we got lots of questions. Rural America doesn't get much of the money from the healthcare system. 20% increased incidence of all chronic diseases, including the ones you're focused on. A 3-year shorter life expectancy than urban America for that very reason. So if you're curious, and remember, 80% of questions are statements in disguise. So just because you're asking questions doesn't mean you want to know the answers. If you really want to know the answers, you're going to do something about it, you're courageous enough to take action, and hopefully compassionate as you do it, you'll get people to think differently about the role they play in making it easy for them and their families to do the right thing. If we can make that difference, and we can begin to get people to, for example, exercise 20 minutes a day, which just by itself we believe could take $100 billion off the healthcare system. Think about that. 20 minutes a day, that run you should have taken this morning, or maybe you did, yoga in your hotel room before you came down. That could generate 100 billions of savings to the U.S. healthcare system just by getting you to rev the engine a little bit. But it's very core. MAHA is about cooperation as well. We've got to get people working together. Folks like you, thought leaders, individuals that are part of that balance of spoke of earlier in your communities, have got to speak up and be heard and be counted. Because I don't think my tenure here is about making cuts, although we are going to improve the efficiency of the system of healthcare in America. It's really about getting aligned on what matters most. And with that, I'll leave you to the rest of the conference. Blessings to all of you for what you're doing. Take care.
Thank you, Dr. Oz. You packed a lot into a brief address. Perhaps most important was that you have hope, because there are things that we can do to make a difference. Yes, there are. I was delighted when you said that getting people to exercise just 20 minutes a day could save $100 billion in healthcare costs. The National Forum's Move with the Mayor initiative brings changes that make a difference to over 200 communities across America, including enabling people to move. Move with the Mayor also strengthens many of the upstream conditions you outlined that are cornerstones of chronic disease prevention, such as exercise, healthy eating, sleeping well, and I loved how you said this, making peace with the world around you. We're helping mayors strengthen those vital conditions for health and well-being, and we're collaborating with National Forum members to extend and amplify that impact. I'm glad you highlighted that rural America has a 3-year shorter life expectancy than urban America. We will talk later in this meeting about how we can close that gap. You pointed out that AI could be used for good. We'll also hear more about innovation later in this meeting. Dr. Oz, the National Forum is grateful to you for being our keynote speaker today. We give you a dose of Dr. Melnick's vitamin G, that's gratitude, and we look forward to continuing our dialogue with you. For 22 years, the United States used advances in treatment and prevention to make significant progress in reducing the leading cause of death, cardiovascular disease. Between 2000 and 2015, we reduced the death rate from heart disease by nearly 35%. But as documented in the National Forum's 2017 signature report, authored by our Chief Scientific Advisor, Steve Sidney, we suffered a reversal of the trend. These two graphs show starkly the rising heart failure and stroke death rates. The report title, Wrong Direction, summed up the message aptly. This wrong direction contributes to America's health deficit. As Dr. Milnick pointed out, among our peer nations, the U.S. ranks last in life expectancy despite spending the most on healthcare. I think all of us participating in this meeting know that prevention is the key to getting back on track towards lower cardiovascular disease death rates and closing the health deficit. There is abundant gold standard science that shows us what to do. It tells us what's been proven to work. The great question we must answer now is how to drive attention and resources towards prevention, both in healthcare and the vital conditions for health and well-being. Can we, as champions for a heart-healthy America, capitalize on the increasing recognition of this health deficit from policymakers and increase resources and attention on prevention? Our first panel will help us identify key leverage points to drive attention, resources, and vital conditions toward preventing cardiovascular and metabolic disease. Our speakers are eminent, knowledgeable, insightful, and dynamic. They're so dynamic that I predict this will be the fastest hour you've ever spent at a conference. I could take the next half hour listing their experience and honors, but we want to hear from them, not about them. So I refer you to their bio sketches in the program book. Our panel members are Dr. Don Lloyd Jones, the Alexander Graham Bell Professor of Medicine and Director of the Framingham Center for Population and Prevention Science at the Boston University Chobanian and Avedisian School of Medicine and past president of the American Heart Association. Dr. Eduardo Sanchez is the Chief Medical Officer for Prevention at the American Heart Association and a former Texas Health Commissioner. And Dr. Anne-Marie Navarre is Associate Professor in the Departments of Internal Medicine and Population and Data Sciences at UT Southwestern Medical Center and a National Forum Advisory Leadership Council member. Dr. Lloyd Jones, please start us off.
Well, thanks so much, John. And, where I'd like to start is to thank you for allowing me to be a part of this panel and join my great colleagues and you to discuss about this incredibly important issue. And so we thought that, I might start with just some framing slides to get everybody on the same page and to level set a little bit about where we are in terms of our health deficit. And so looking here, you see sort of the classic representation now expanded of the prevention pyramid. And the way that I think about these different levels of the prevention pyramid are from tertiary to secondary to primary to primordial. And defining those, as you see here, tertiary prevention really is, especially in cardiovascular medicine, is focused on a patient who's having an acute cardiovascular event. They are in the emergency room or in our ICU. And our goal here is to prevent death and to preserve as much heart and brain function as possible during an acute stroke or an acute heart attack. A level down from that is secondary prevention. That is, in people who have already had a heart attack or stroke, can we prevent them having another one? A level down from that is what we call primary prevention. This is in our doctor's offices, typically, can we identify those people who have risk factors for having a first heart attack or stroke? And can we actually intervene to control those risk factors and prevent those first events? And then the big part of the pyramid at the bottom, sort of the new kid on the block, primordial prevention, which really focuses well upstream, where we're trying to prevent the development of the risk factors in the first place. As we'll talk about in a moment, if you don't develop the risk factors, hypertension, adverse cholesterol levels, smoking, unhealthy body weight, unhealthy blood sugars, it's actually really hard to have a heart attack or stroke if you don't develop those first initial risk factors. So primordial prevention really focuses well upstream, both in the life course, but also in our sort of thought processes of how we can prevent disease and promote health. Next slide, please. Now, if you think about this pyramid, there's some implications from this pyramid, and there are also some things that are important to understand about how we currently approach prevention. The first is, as you see on the left, the number of patients affected at these different levels of the pyramid varies vastly and widely. In tertiary prevention, we're talking about a relatively small number of patients who are, at any given time having an acute heart attack or stroke. As you go down the pyramid, the numbers increase dramatically, really by orders of magnitude. So in primordial prevention, we're talking about really the large proportion of the population that is under age 50 is eligible for primordial prevention. But our current areas of focus in terms of where we spend our money are completely inverted from that. We spend the most money per unit, that is per life saved or per, quality adjusted life year extended, or however you want to measure this. We spend the most money at the top of the pyramid where we're affecting the fewest people and actually probably gaining the fewest numbers of life years possible. So perhaps our incentives are misaligned here, and that's something I know we're going to talk about. And finally, on the right side, you can see where these different types of prevention actually occur, what settings or points of care they occur in. So tertiary prevention being really exclusively a healthcare issue, all the way down to primordial prevention, where there's probably more we can do with public health policies than we actually can specifically in the healthcare setting, but certainly there are things we can do in the doctor's office as well. Next slide, please. So I want to emphasize this. There is absolutely no mystery about what causes cardiovascular disease, heart attacks, strokes, heart failure. Estimates from a number of different sources would say that 80 to 90% of heart attacks, strokes, and heart failure events could be prevented entirely or at least postponed to the end of life if we focused on the direct causal risk factors. And you see them again listed here. Taking a look at this from the flip side, we have data that show that actually if you take anybody coming into the hospital with a heart attack or stroke, if we had been carefully monitoring them over time, 90 to 99% of those people had an identifiable risk factor that could have been modified before they had this clinical event. Again, just telling us this is not a mystery. We know actually the things we need to know to prevent the vast majority of these events. And not only is it that people have just one of these things that might have slipped through the cracks, most people have 3 or 4 of these modifiable risk factors antecedent to the event or before the event of their heart attack or stroke. And so these really represent, I think, failures of primordial prevention, failures of screening to find those risk factors, failures of recognition, perhaps on the part of clinicians or others, to actually say, oh, yes, you do have this risk factor, and clearly inertia and failures of action to actually address and modify those risk factors and improve them. And these are data from the Framingham Heart Study long ago when I was a fellow. And the take-home point here is that if you look at people's risk factor levels at midlife, at age 50, if they have 2 or more major risk factors, the remaining chance that they're going to develop cardiovascular disease before they die of something else is really high, 50 to 70%. Whereas if they've made it to age 50 with optimal levels of all those causal risk factors, it's in fact quite rare that they're going to develop any cardiovascular disease, perhaps as low as 5 or 8% during their remaining lifespan. So we could think about cardiovascular disease being a rare occurrence if we were actually to refocus our efforts of prevention, especially thinking more about primordial prevention. Next slide, please. So at the American Heart Association, we actually sometimes think about this a different way. Rather than risk factors and prevention, we actually start to talk more about health promotion. And the platform that we've developed at the American Heart Association is called Life's Essential 8. The 8 factors that if you can keep them at optimal levels, actually will drive much longer lifespan, more years in the life, but also more health span. That is more life in the years. And I think this is a really helpful way for us to think about things with our communities and with our patients. Turns out that a lot of research onto Life's Essential 8 tells us that even small changes in one of those 8 metrics can make a big difference in your future health status and your outcomes. It's never too late to try to change one of these 8 factors. And the earlier you start, the better the results will be. You see on the right there, the Life's Essential 8 icon, which enumerates the 8 things that go into this construct. They are eating a healthy diet, participating in physical activity, avoiding nicotine, and getting a healthy quantity of sleep, but also healthy quality sleep. And then the other 4 things are the things that we need to measure in our doctor's office, know our numbers, and make a plan about. Our blood pressure, our cholesterol levels, our body weight, and our blood sugar levels. So taken together, those are the 8 factors of Life's Essential 8. And again, I think they can provide a nice framework for us to think about this at both the individual and the population levels. Next slide. So this is a recent publication that shows us that if you have better cardiovascular health, it will influence better health from the tip of your hair to the tip of your longest toenail. Everything is affected by cardiovascular health. All of our organ systems are actually improved when we improve our cardiovascular health. So this is a really important way, I think, to frame the conversation with people, not just as the absence of disease, but actually the promotion of health. Next slide. And thinking now about what the panel is going to talk about, this is a study done by one of our fellows, and he asked the question, if we could magically snap our fingers and give everyone in the country high cardiovascular health or optimal cardiovascular health, what would be the impact on the numbers of heart attacks and strokes that we see in the country every single year? So if you click one more slide, if we could snap our fingers and give everyone, all adults, high cardiovascular health, we would actually prevent 2 million heart attacks and strokes every single year in this country. And imagine the cost savings that would entail. And if we could only snap our fingers and go ahead and advance the slide, and create 50% of the people magically having optimal cardiovascular health, we would still prevent 900,000 cardiovascular events each year. Pretty remarkable statement. And so kind of tells us where we should and could be investing our money rather than where we currently are doing so. Next slide. So how's it going so far? Well, John, your slides, I think, alluded to this as well in the really wonderful work by Steve Sidney. Here's some data showing that not only have we plateaued and seeing some reversals of our gains in cardiovascular death rates, but there are differentials in this country. There are disparities. What you see here is in the dotted lines for each different color in terms of a demographic subgroup, people who live in rural areas always have worse outcomes than people who live in urban areas. And there are many things, of course, that go into this, healthcare access not least, but we're not closing the gap at all for people living in rural areas. And the next slide, you see the same kinds of data for people in terms of how they identify by race ethnic groups. These are pre-pandemic data. But what you see here is that while we've seen declines generally in total cardiovascular disease mortality rates over the ensuing couple decades, we haven't narrowed that gap. So the people at the highest risk for cardiovascular disease mortality identify as non-Hispanic Black. We've seen some progress, but they're still far, far above any of the other sociodemographic groups in this country. So we have a lot more work to do. So hopefully that will kind of set the stage for the comments of my colleagues and the panel discussion that's to come.
Thank you, Don. That was a great introduction for the challenges we're going to tackle with this discussion. Eduardo, I know you've done a lot of work that's closely related to what Don just showed us and to the pyramid about the pyramid of care, the pyramid of investment. What's that look like? What kind of changes would you recommend?
Sure. Don, that was great. And John, thank you for having us. Conversation that we all wish would turn from words to action, and maybe this will help make that happen. Here's what should be. Don made a good case for why we need a system that looks like the pyramid he showed, the triangle that I'm showing with public health, primary care being the base, specialty care and acute care being up higher for all the reasons. We saw the case was made. primordial prevention is the way to extend long, healthy life. But when we look at where the dollars are spent, next slide, and I've put a little bit of numbers behind the more qualitative characterization that Don had present, whereas only 3% of the population at any given time is needing hospital care. And oh, by the way, when they need hospital care, we need to provide hospital care. But that represents a very large percentage of all the dollars that are spent on healthcare in the United States, over a quarter of the dollars spent. In specialty care, that's the place where we get into, as Don said, secondary prevention. Something bad has already happened, or some bad things have been discovered along the way before that bad thing happened. 17% of spend, about 1/3 of the population is seeking specialty care at any given time. Going down further, whereas that same percentage, roughly 35%, are in a primary care setting where, oh, by the way, just to talk about hypertension, 75% of hypertension care happens in primary care settings. The degree to which it happens well might be to the degree to which we avoid that bad event that leads us to secondary prevention and or specialty care, 35% of that volume. And the most challenging, but one that holds the most promise for us, the combination of public health and primary care. On the public health side, less than 3% of healthcare spend is on public health in the United States. But I think there's no argument that 100% of us need the public health interventions 100% of the time, whether that's no smoking laws, whether that's the programs that are in place to help us eat healthier and be physically active. One thing you said, John, that I want to refer to, you showed a slide about how much more we spend than so many other countries and yet have lower life expectancy. And I know Anne Marie's going to talk about this later. Part of that is, and you alluded to it, it's what we spend our money on. And whereas we spend more than 2/3 of our dollars on clinical care and less than 1/3 of our dollars on public health and social services. And let's just kind of put those together in public health. In those other countries, the ratio is flipped. And there's a higher percentage on public health, social services, primary care, which results in a higher percentage of folks achieving primordial prevention, and therefore, back to what Don was saying, keeping hundreds of thousands, if not millions of events from occurring. Last thing I'll say is we're talking about the what, and I just want to put a little bit of the how. And one of the things that we've learned along the way is that we need system-wide, standardized, protocolized, monitored approaches to the work we do so that we can be sure we're doing the evidence-based work. We can be sure that when we do it, we're doing it to the way it's described in the articles and things that tell us what to do, and that we monitor what we do so that if we're not achieving what it is we're trying to achieve, we can begin to understand why that is, modify what we're doing, and again, in a system-wide, standardized, protocolized way, continue to improve so that we achieve those better outcomes. So I'll stop there. Oh, I forgot this. This is the system. This is the system we have. And that's the one where when you spend more on acute care and specialty care, you basically create an unstable structure. We all know that if you turn a triangle on its corner, it's going to fall over. It's got to be on its base. That base should be public health at the bottom. So thank you for advancing that slide and getting me back on track. I appreciate it. Back to you, John.
And Eduardo, if I may, tying what you just said and what Don said together, Dr. Lloyd-Jones's emphasis on primordial prevention, that would be, as you pointed out, in the public health line, the public health portion of the triangle, which should be bigger. We at the National Forum, people will remember, I think, some of the people in the audience today, I know, are using the framework I'm about to say. When instead of saying primordial prevention, we've shifted to talking in terms of the vital conditions for health and well-being. Those are the things, some people refer to them as social determinants of health. The vital conditions encompass the social determinants and more. And those are the factors, the building blocks in communities and in society that make up primordial prevention, that make it possible for people to enjoy primordial prevention. Eduardo, you talked about us being upside down, and it's not that we don't spend enough, it's how we spend it. And to just put a fine point on your comment, it's so uniform in all the other OECD countries, meaning like European countries, US, Canada, Australia. If you look at every country except the United States, for every dollar that they spend on healthcare services, they invest $2 upstream in those vital conditions for health and well-being, in that what should be the bottom, the base of the pyramid. In the US, think about that. $2 in the vital conditions for every dollar into healthcare. In the US, it is literally upside down. For every dollar that we spend in the US on healthcare services, we're only putting in 55 cents into those vital conditions. So Anne-Marie Navarre, I'm reminded of something when you were at Duke, before UT Southwestern, your Duke colleague, Mark McClellan, says all the time, almost like a mantra, the United States gets exactly the results that our healthcare system is designed to produce. So it's broken. Where would you suggest we start to fix it and make it better so that it can serve people better, and so that we can make this shift into the primordial and primary prevention that Dawn and Eduardo just talked about? Where would you start?
Well, thanks, John, and really excited to be here to talk about this. I think you started off nicely by reminding us to go to the evidence base. And for some of this, it's really not rocket science. It feels really big to talk about how do you prevent obesity, physical inactivity, all these things. But we actually have some really good data around really successful programs. One of those I'll point out is the diabetes prevention program. We studied this in a large clinical trial where we showed that if we support people with the right lifestyle and physical activity advice, and we educate them well, we can get people to make the right lifestyle changes and dramatically reduce the risk of developing diabetes. That study was successfully transitioned into a national program that was supported by the federal government, deployed through the Centers for Disease Control, through our local, state, and local health agencies, where we have diabetes prevention programs throughout the United States where people can access these programs. We need to double down on this. We need to fund more diabetes prevention programs, and we need to do a better job of getting access to those programs to people who need them. There's also ways that we can invest in sort of the environment that we live in. Where I live, I have a protected walking trail that I can go walk safely and get physical exercise. I have bike lanes that I can bike around, and I live within a mile radius of several grocery stores where I have access to healthy foods that I can feed my family easily and at a reasonable price. But that's not true for many, many people in the United States. So investing in infrastructure to make it doable. When I tell a patient in clinic, if you don't have access to a gym, go walk or bike, that's not realistic if you don't live in a place with that kind of access. There's other funding we can do. We can support recreation centers that can have exercise programs that can reach communities that don't have an environment that's conducive to outdoor physical activity, either because of safety or environmental reasons. So there are things that we can invest in that will both work from a evidence sort of targeting things like diabetes, or creating infrastructure that promotes parts of those life's essential 8 which is just unrealistic for us as clinicians to talk to our patients about if they don't have access to the fundamental facilities to do it.
Yeah, Anne-Marie, those are great examples that you gave. I want to make sure that we call out the very important role that community-based organizations play in providing the diabetes prevention program to people, to real people in real communities. So the Y, for example, is, I think, more people may be served with the diabetes prevention program through the Y than any other providers. So it's not only public health agencies who are making it happen, but it's being done in concert with these other resources at the community level. And that takes investment. I mean, you can't save the world if you can't pay the rent. And that takes funding. When you were talking about infrastructure, I was thinking, okay, that takes money too. And so when you hear people say, well, we need to be careful with our spending, how do you respond to that? I know you spend a lot of time doing very good work in the community, talking with not patients, but people, and helping them understand how they can take charge of their health, that they don't have to leave a potential heart attack or stroke to fate. They can take charge. And you're not only educating them about that, but also about how it fits into society. So when somebody says, oh, we have to hold the line on spending, how do you respond to that?
I think we can't afford to keep doing things the way that we've been doing. When I save for retirement, I don't have as much money right now in my bank account because I've put it in my retirement account where it's going to grow and I'm going to reap the benefits later on. I think we need to think about investments we make today in primordial prevention the same way as you might think about buying Apple stock in 1980. It's going to pay for itself over and over and over again in the future. We won't reap the benefits immediately. So we're going to have to accept in the short term that when you put money into primordial prevention, it's going to take time for us to see that pay back by reducing that tertiary and secondary costs that we heard about earlier from Don and Eduardo. The good news is that unlike private insurance companies who are usually talking about a 2-year time span, when we're talking about government funding, we're all in the same country and we're all going to be sharing the costs in several decades of the choices that we make now. And I think where we choose to invest money now will dictate where we're forced to spend money later. So if we make the choice now to invest in prevention, then we won't be forced to pay so much on the back end and secondary and tertiary. But the reality is true. We're going to need a groundswell of support to invest in efforts that will pay off later, but we can't rush it. It takes decades to develop heart disease. The hypertension that a 20-year-old has now or that a 20-year-old is going to get in 10 years won't turn into a heart attack for 30. But that doesn't mean it's not worth it. If we look down the road at how much money we save by preventing just a fraction of cardiovascular events, the economics are pretty obvious.
That's such a great point. Ties back to what Don was saying about, I'm not sure he used this term exactly, but the accumulation of risk over a lifetime. And I know, Don, you've played a very large role in gradually moving the standards, moving guidelines and recommendations for U.S. healthcare toward addressing cardiovascular and metabolic risk factors earlier in life. How far should we go on the age spectrum? Where should we begin to start paying attention to some of these important risk factors that will spell the difference between whether someone is likely or at risk of having a heart attack in their 40s or 50s versus living independently well into their 80s or 90s.
Yeah. Well, I did, just to endorse everything Anne-Marie said, as I often do, because she just says it so well. This is a life course disease. It really starts in early life, and we can document that histopathologically. But it takes decades for this disease to develop, which means there are decades of opportunity for us to intervene. I think thinking about this generationally or across the life course, we have 2 generations of people right now who need preventive care with medications. Right? We're just not going to escape the risk that has already developed because of their cumulative exposures through their early decades of life. But that can be done actually much more cheaply, much more effectively than we're currently doing it with the right choices. And you mentioned the hypertension guidelines. We put a premium on combination therapies of generic medications where we minimize the side effects and we maximize the synergy between more than one type of medication to control blood pressure. Absolutely evidence-based gold standard science that shows us not only that it works better, but patients appreciate it and they will adhere better to those therapies. So we have plenty of options to do this better in the primary and secondary prevention space. But moving upstream in the life course, yes, we need to get more engaged with our young people to make sure they are not developing those risk factors in the first place, primordial prevention as we're talking about it. But actually, much of the stage is set really early in life. We need to invest in very early education of parents and of children in schools and in other settings to make sure that we're launching them into healthy habits of diet, physical activity, and healthy weight maintenance. If we win there, much of the downstream consequences of those adverse health behaviors don't ever appear, especially if we limit weight gain to what is healthy and appropriate. So, these are strategies that we know can work, but I'm going to even move it even further upstream, because here's where the feed forward virtuous cycle comes into play. Healthier moms and dads, but especially healthier moms, have healthier babies that launch into healthier trajectories, become healthier parents themselves, and in turn have healthier babies themselves. So, investment, particularly in our young people who are going to be the next generation of parents, will pay huge dividends as time goes by.
Don, I love what you said, and one thing that particularly jumped out, everything you just said was important. One thing that jumped out at me is your use of the word invest versus spend. And it brings to mind what I heard a Fortune 500 CEO say one time, which is we need to understand that health is not an expense or a cost to be minimized. It's an investment to be maximized. And I'm hearing you frame it that way. And I think that could be powerful as we all work to shift the priority and the flow of resources toward prevention, to shift it upstream or down to the base of the pyramid, whichever illustration we use. Eduardo Sanchez, you are responsible as commissioner for health in the enormous state of Texas. You are responsible for millions of people's health. Thinking on that scale, if you're trying to move the needle in the right direction here, Don showed us life's essential aids and all these different factors that affect health. We know it's multifactorial, but we need to start somewhere. So where would you suggest we start? Where do we begin to build blocks and a foundation that we can climb in order to reverse the trend in the United States, get us back on the decline of heart disease, heart-related deaths, and improving health for everyone, everywhere?
Thank you. I love that question. There's a few themes that have emerged. One I would say is that life course is really important. I don't think it's an either or proposition around this. It's an and the and is where are you spending your money and where are you investing your money. I'll take that. And the other is that it's never too late. So in the it's never too late frame, where I would spend my money, and I've spent a little bit of time thinking about and working in the space, would be first to start with trying to tackle blood pressure control in the United States of America. That is a place where actually dividends could be realized almost immediately in terms of lives saved, events prevented, lives saved, and maybe dollars that then could be thought about being reinvested in different places. Having said that, though, I'm going to stop for a second and say probably all of y'all in the audience is aware that what was then the Institute of Medicine did a study about a decade ago that found that there was approximately $750 billion of, I would call, injudiciously spent healthcare dollars. Some people use the W word, waste. I won't call it waste because for somebody it wasn't waste. It may not have been the best use of dollars. And so I also believe that there are opportunities to find some resources by streamlining the way we do things, which brings me back to let's focus on high blood pressure. Let's use a program like Target BP, which is an AMA, AHA blood pressure improvement initiative, system-wide, standardized, protocolized, monitored blood pressure control program that has demonstrated that those who participate over time achieve higher levels of blood pressure control among people with high blood pressure. And Don and Anne Marie know when you do that, you reduce the likelihood that next week someone's going to have a heart attack, a stroke, or experience heart failure. If we can monitor that a little bit better and begin making sure that the dollars and lives that are saved begin accruing to that part of the system, primary care and public health, that can then accelerate and achieve that positively reinforcing cycle, we can begin to turn the direction of this gigantic cruise boat and go in a different direction. I do think that another important point to be made is that the public health, social services, primary care triad is the solution, because good primordial prevention is going to require a primary care element as well, so that the clinician can say physical activity and healthy eating are the key. And oh, by the way, I know that in your neighborhood, 1 block away, there's a really nice park. And I know that not too far away, a new store has opened that is making it economical and possible for you to buy healthier foods than what you thought was possible with the dollar you have in your pocket.
And, I'll mention here, we've talked a lot about things that require money to be spent, but not all legislation focused on primordial prevention costs any money at all. In fact, some of it makes money. There's really good data suggesting that the precipitous decline we've seen in smoking rates is attributable to a combination of taxes on cigarettes, which are revenue generating, and laws that ban indoor smoking. So significant declines in smoking, not because doctors told people it was bad for them, but because we made it expensive and inconvenient to smoke in the first place. South Africa passed a law that limited the amount of sodium in processed foods. And recently in JAMA Cardiology, Tom Gaziano and colleagues published a really great study showing reductions in the amount of sodium that people were eating, which they measured with urine sodium, and blood pressure in people who lived in South Africa after that law was implemented. That's free for us to do. That didn't cost the South African government a dime to maybe a dime for the paper it was written on. But there are legislative approaches that can change financial incentives or even limit things like smoking indoors that can cause really important public health changes. We spend a lot of money on food subsidies, and there's a lot of money that is spent to support farmers and the agricultural industry in the United States. How can we use that money to support lowering the cost of healthy, non-caloric dense foods like fresh produce, a Mediterranean diet, the kind of things that we recommend? It's much cheaper right now, largely driven by how much it costs to make food, but also how much people are subsidized to produce that food. It's cheaper for me to buy highly processed, calorically dense, high carbohydrate food than it is for me to buy fresh vegetables. Now, I think there's a lot of sort of potential innovation that can be done at the policy side that wouldn't require additional investment. But thinking about what can we do to sort of redirect the funds that are already going into our food system to support healthier food and better food choices. We've done it with smoking. Other countries have done it with sodium and blood pressure. I think we've got a lot of potential there that is still untapped. That actually isn't going to cost any money for us if we're really thoughtful about it.
Wow, you just packed a ton into a couple of minutes. That's why I said this will be the fastest hour that anybody's ever had at a conference. That was so rich. Thank you, Dr. Navarre. So I think very important reminder that some of the most powerful public health or health improving interventions are also ones that cost the least, such as clean indoor air laws. That's such a great point. And in many communities, there's plenty of room to expand them into smoke-free housing and other opportunities to free people from toxic environments and create more opportunities for people to live healthy lives.
John, can I just pile on for a second? Because,
please.
Like you said, Anne-Marie just opened up a wonderful Pandora's box of really important points. And, we don't have to create the wheel here. The Finns have been doing this for over 50 years with these sort of legislated and also sort of dictated common sense public policies that cost little or actually generate revenue, as Anne-Marie pointed out, and lead to very rapid and remarkable declines in acute event rates and deaths. And it works. And if you say, well, that's Finland, well, it worked in Franklin County, Maine as well, with a very, very similarly designed intervention with great outcomes in terms of risk factor levels. So
right.
It can work here in the United States as well. This is not something that's pie in the sky or out of reach.
Absolutely. Thank you. That is such a great point, Don. Anne-Marie, I want to come back to you for a second. Eduardo suggested beginning with blood pressure. I think of you as one of the world's foremost lipidologists. So how does beginning with blood pressure management hit you?
It's all together. I think of prevention as a rising tide floats all boats. When you go to the doctor to get your blood pressure checked, you also have your cholesterol checked. You're also, if you're at risk, more likely to get your hemoglobin A1C checked to see if you're at risk for diabetes. Access to good primary care, which Eduardo mentioned, means access to all of the screening. It's very unusual to be diagnosed with hypertension, but not also get all of the other screening tests that you would need at the same time. Yeah. Unfortunately, the inverse is also true, that many of the people who are unaware of their hypertension are also unaware of their diabetes and their high cholesterol. I think if we see these risk factors as silos, then we're setting up a false sense of competition between them. Many effective public health interventions often combine screening programs together. And the good news is you can make benefits by treating one or all of them. The bad news is having normal blood pressure doesn't offset the risk of high cholesterol. So we have to think about them as an entire package, but it actually works. That's how people think about their health. That's how doctors think about their health. So we should think about it from a policy level as well.
So, John, I just want to say I'm going to completely agree. Hypertension, high blood pressure is kind of the best hook because one, it's easy to test out in a community without having to stick people with needles or anything. Secondly, you can begin to see a change fairly quickly if you follow the guideline. You can actually demonstrate to somebody that, hey, your blood pressure is coming under control. But study that was done among people who had the cardiovascular disease risk profile that included likelihood of or the need to control diabetes, cholesterol, and hypertension. And just to add a note to what Anne-Marie is saying, when you do one of those, and I'm going to get these numbers a little bit wrong, but directionally this is right. When you do one of those, you might bring somebody's risk of a bad event down 30 to 40%. You do two of those, you bring their risk down to 50%. You do all three, you reduce the likelihood of a bad event by as much as 60%. And the degree to which that is actually happening in primary care settings or any settings is abhorrently low, and yet another opportunity to very quickly say, if we did things in a system-wide, standardized, protocolized, monitored way, and held ourselves to account to deliver what we should be delivering, some of those dividends of longer life and dollars spent more judiciously would allow us to invest even more in primordial and primary care. Primordial prevention, public health, and primary care, the 3 Ps.
That's a great point. And I'm wondering, would spending judiciously involve guideline-directed care?
Oh, yeah, right?
Absolutely.
Absolutely.
So let me ask you three, as clinicians, we just received the new high blood pressure management guideline. Thank you, Don, and the other writing committee members for that. The last guideline, the one that replaced, the last one was issued in what year, Don?
For blood pressure, it was 2017.
2017. Okay. Here we are in 2025. Had the 2017 guideline fully penetrated medical practice, clinical practice? Was everybody following that?
Absolutely not. And I think there are huge issues of implementation of guidelines that are wicked problems in and of themselves. And, I know that American Heart Association, its partner, American College of Cardiology, and the other 11 professional societies that actually developed this high blood pressure guideline are all now intensely focused on implementation. And to be honest, we spent more time on implementation in this guideline than I've ever seen before. And I think the tools and the things that are coming to help clinicians and patients actually better live out the guideline-directed medical therapy for blood pressure are coming. Without saying too much and giving away the farm, I think clinicians will be pleased that there's a whole suite of guidelines coming that are going to focus on many of the issues we're talking about today from AHA, ACC, and our sister societies. But what's really important also is, 8 years between hypertension guidelines is too long. And so there's been a whole revamp of the process. And so now a panel of guideline experts is convened for a full 5 years. And each year there will be an update based on the latest science and the best science. It will be vetted to make sure that actually those guidelines are not waiting 8 years to update recommendations. They will be updated annually, and that will be disseminated quickly to the public. So I think, I think we're addressing some of these problems. Implementation remains a very, very big problem, but we're solving some of these problems. And I hope that with Eduardo's in particular, approach of systematized, protocolized care that involves care teams not only relying on the physician alone in their office to manage these things, we're going to actually start to make some real progress.
Team-based care is one of the recommendations, and judicious, I'm loving that word today. It's not weekend language, but I'm loving the word. If you watch enough Law and Order shows, judicious comes up. Judicious use of electronic health records to help with that monitoring. There's so much information in there that can help clinicians, practices, and systems get a sense of what they're doing with regards to blood pressure control, cholesterol management, diabetes management, weight management, and even counseling on the things that we need to be systematically doing. Don't smoke, eat healthy, be physically active, sleep plenty, and now if you have high blood pressure, don't be drinking.
But let's be realistic here, because I think it's a little bit unfair how much we're putting on primary care. Our system does not incentivize primary care to do all the things that we expect them to do. Primary care physicians are amongst the lowest paid of all doctors, although they have the most work to do. When you see your primary care doctor, not only are they handling all the problems that you've been saving up all year to bring to them, but they're making sure that you're up to date on all of your screenings. They're talking about all the misinformation. They're trying to talk to you about exercise and diet and lifestyle. And they've got 15 minutes to do it, and they're barely breaking even given how much they're reimbursed for that. In comparison, you can do one MRI and cover the amount of money that you make in a health system to do an MRI is more than you get for like the entire primary care for a child through like your teenage years. As a result, what happens is we have a shortage of primary care doctors. Most of primary care doctors are reporting high levels of burnout, so we're losing some of the best ones. People aren't satisfied with their relationship with their doctor because they're not happy with the system. So they're not going to the doctor and seeking that preventive care. And even those who want to often can't get an appointment. So if we're going to actually invest in prevention and think about the primary prevention realm, we're going to have to change the reimbursement model for primary care. We have to value it as much as sort of the degree to which it is important. Because right now, the way that we value it, at least financially, says that this does not matter. And so when we expect our primary care doctors to see the patient with hypertension, have a comprehensive dietary assessment, talk to them about lifestyle, bring them back to follow up their blood pressure multiple times, titrate the meds, pay attention to the home readings, answer their MyChart messages, deal with the prior authorization for the refill, it's just not realistic. So I think that
Amen.
We've got to do a better job at supporting our primary care colleagues, or we're never going to actually be able to bend the curve on hypertension.
So we're getting close to, unfortunately, the end of our discussion. So I'm going to try to boil what you just said, Dr. Navarre, down to a few seconds, which was we have an unreasonable burden today on primary care providers. And further, that's made worse or harder by the fact that misaligned incentives mean that they're paid the least. Now, Eduardo, just a couple of minutes ago, mentioned team-based care, and it made me wonder as I was listening to you, Anne-Marie, are there other types of providers who we could be using better or drawing upon more advantageously to try to fill some of these gaps and to reduce some of that burden on primary care so that those providers can do what they do the best? Are there others?
The short answer is absolutely. We know that pharmacist-led hypertension and cholesterol and diabetes programs work. We can train nurses. In fact, we've even seen programs that use health navigators of non-medical people who are supported by clinicians, pharmacists, doctors, can all do this work. The problem is we live in a very sort of patchwork of laws from state to state, and who can bill and how much they're reimbursed. So it's cumbersome for programs to be sort of developed and rolled out nationally because of differences in practice laws and also differences in reimbursement. We did see there is possibility to get rapid standardization of these things. We saw during COVID rapidly across states. When before COVID there was another patchwork of telehealth laws and could you bill for visits and not. And then COVID hit and we magically were able to just get it done. And we're all able to do telehealth and adapt our system in response to an emergency. So if we could see hypertension as the kind of emergency that it is, and rapidly adapt our laws to figure out how can we change the system to enable the team-based care to be done, I think it would work. But we have to have a little bit more of a sense of urgency about it than we have right now.
Oh, sense of urgency. Wow, you saved three of the most powerful words for our final couple of minutes here, Dr. Navar. Sense of urgency. Yes, we need to stoke that. We're in the last couple of minutes, so I want to attempt a quick recap here. I've heard from the three of you that we need to shift investment and action upstream or down to the base of the triangle to invest more attention and resources in primordial prevention, or what we might call the strengthening the vital conditions for health and well-being, and to do that in concert with public health and strengthening primary care. Second, we need to start paying attention to cardiometabolic health and the risk factors much earlier in life. Although the corollary to that is it's never too late. And invest in what works. We have a plethora of evidence-based policy changes, of system changes, environmental changes, and programs proven to work. So we know those are good investments. And then a good starting point would be blood pressure management and control. Focus on that, and that's going to lead to a cascade of health improvements and reductions in multiple risk factors. I don't have time to ask. I see Eduardo nodding. Thank you. So because I don't have time to check to see if I got that right, but I do have just enough time for the magic wand question. Anne-Marie just talked about how COVID came and magically all these barriers to telehealth melted away and we were able to get that done quickly. If each of you could wave a magic wand and make one change that would start the U.S. on the course that you've outlined here, that will get us to closing America's health deficit, what would that change be? Where would you begin? Eduardo, you're nodding, so you get to go first.
Sure, I would double the spend on primary care and public health from not where it is in the moment, where it was, let's say, pre-pandemic. Double the spend on primary care and public health. It may not be enough, but it's enough to get us, get things started in a pretty dramatic way.
You're talking double or shift?
I'm talking about double. Double the spend. That would, I mean, you know, as Anne-Marie was saying, in both public health and in primary care, we are not spending enough. And it's not that everything requires more money, but as I like to say, if you only have enough gas to get from Dallas to Waco, you're not getting to Austin. So you have to have enough gas to get you all the way there.
That's a great illustration. Dr. Lloyd Jones.
Yeah, I'm going to expand.
Where would you wave your magic wand?
Sure. I'm going to expand our definition of primary care into pediatrics and really endorse all the things that Anne-Marie said about the importance of setting up our clinicians to succeed. Because again, every time we look at young adults or middle-aged adults, it's, you know, much of the horse, not all of it, it's never too late, but much of the horse is already out of the barn. We need to launch our children with comprehensive programs that are public health based, that are pediatrics based, into much, much healthier trajectories of lifelong cardiovascular health. And so I think, really focusing on starting early, supporting families, avoiding food insecurity, helping kids develop really robust senses of what are good, healthy choices from the beginning of life is going to be that investment that's going to pay, again, that sort of virtuous cycle of dividends that will play out over many generations to come. So that's where I would focus my work, is on maintaining and promoting healthy childhood, especially avoiding that unfortunate weight gain that we're seeing in far too many of our kids.
Thank you. All right, Dr. Navarre, bring us home.
Well, I think if I could only have one wish, it would be that all of our politicians could realize that everybody is on the same side as it relates to preventing hypertension, diabetes, high cholesterol, and heart disease. Acknowledging that violent agreement that we want to prevent heart attacks, go to the evidence base and implement the evidence-based policies that we know improve access to healthy foods, improve access to healthy environments to facilitate physical activity, limit exposure and access to tobacco and nicotine, and improve access to screening and primary care to identify risk factors early and get them treated. These should not and are not partisan issues. And I think that if our politicians could focus on where we all agree and actually get some of these policies implemented, it doesn't matter where we are in the political world, we actually can see some real progress get made.
That is so well said. I have to put an exclamation point on it and just say that through the National Forum's Move with the Mayor initiative, and I know you, Dr. Navarre, you've been involved with that. Thank you for that. We work with 200 mayors who are Republicans, who are Democrats, who are independents across the country to improve health and to use evidence-based policy and environmental and system changes in their communities to make it easier for people to attain health. And one of the things that keeps me energized, keeps me going, goes right to the point you just made, Dr. Navarre. These aren't partisan issues. It's so exciting to me to see Republican, Democrat, and independent mayors rowing in the same direction. They all see the benefit to their communities and their community members of having a healthy population and making it possible for everybody everywhere to attain health. This has been such an exhilarating panel discussion. You three are terrific. You're heroes. You're in the Mount Rushmore in my mind's eye. So it's been a privilege for me to be part of this conversation with you. Thank you so much for contributing to this discussion and for helping us think about investing more wisely in prevention. We will now open the floor for questions. Dr. Lloyd Jones had to return to the clinic, but Drs. Navarre and Sanchez are still with us. So please use the Q&A feature at the bottom of your screen and ask them questions. We already have several questions in the hopper. First question I want to pose is from Dr. Sanchez's colleague at the American Heart Association, Jill Birnbaum, who asked, with the cascade of changes coming to state Medicaid programs, I wonder if you can speak to how that program impacts heart health and what you think we need to do as a community to protect it.
That question to me from Jill Birnbaum, who oversees that, and I'm just a family practice doc. I'd say that the things that Medicaid does are many of the things that we talked about already for youth in particular, because even before Medicaid expansion, the program EPSDT, Early Periodic Screening, Detection, and Treatment, was a program that was about doing the very things that we need to do that we know work, i.e. childhood vaccinations as an example, but also the counseling that parents need around how to grow a healthy child. One would hope not to have to treat hypertension, diabetes, or cholesterol in childhood. It is a reality these days. The corollary of that is doing a better job in using those opportunities to talk to parents and kids about healthy eating, physical activity, plenty of sleep. We now have sleep on the list of things that we ought to talk about. And of course, no smoking, no vaping. And what do we do to protect? We do everything we can in the spirit of the conversation we had and the comments that Anne-Marie made that say, we're all in this together. We're all in the same boat. And the degree to which we do the right thing for all the people in the boat is the degree to which we will all survive whatever it is that we are trying to survive. So I think the imperative is to make the case for why it's so important that Medicaid and expanded Medicaid are so critical for the health of so many people, and the health of those people didn't mean it to sound that way. The health of all of us depends on the health of each of us. I'll put it that way. Hope that helped, Jill Birnbaum.
Thanks, Eduardo. We have a lot of questions in the hopper. Thank you all for submitting them. Anne-Marie, I want to jump ahead now to a question from Sahana Chakravarti. It's related to the one that Eduardo just answered. It says, how can we help patients understand the gap between the promise of common sense policy solutions to improve preventive care and the reality of shrinking access? I know this is something you've thought a lot about, Anne-Marie, especially with Medicaid cuts and a growing shortage of primary care providers, as you were just discussing.
I wish I had a good answer. I think it's a challenge for our patients, but it's a challenge for us as physicians and people in the health system to actually understand the whole impacts of cuts and reduction to access to affordable care. We know there are trickle-down effects to health systems. FQHCs are a real threat, and they're a huge safety net for us, for our patients who otherwise don't have access to healthcare. What we end up doing when patients lose healthcare is we do our best with limited support. We are fortunate to have, for a lot of these conditions, very low cost generic drugs that are available to be purchased cash for things like hypertension and hyperlipidemia, even diabetes management. So there are therapies available. I think we have to do our best to try to help support our patients in between gaps in coverage and help them get access. But really the best thing that we can do is advocate on behalf of those who are most risk of losing coverage as these changes are made, and making sure that we advocate not only nationally, but at the state level and even locally, where local funds are often critical to supporting community programs that can help bridge gaps in bigger term coverage.
All right. Thank you very much. Our next question comes from it's a food question coming from a former commissioner of the FDA, David Kessler, now from UC San Francisco. Dr. Kessler asks, what is your view of what the dietary guidelines should be? Processed refined carbs are contributing to metabolic harm. What are your thoughts about saturated fats? Should they still be 10% of the diet?
I would love to turn the tables and ask the esteemed Dr. Kessler to answer that question himself. My short answer is I think we need to maintain the same rigorous evidence base for our dietary guidelines that we do all other guidelines, and recognize that much nutritional research is based on observational data, which, as we all know, is highly confounded. We have very few randomized trials of dietary interventions in cardiovascular health, but we should focus on what we have learned from those trials, which is that less sodium, more potassium helps prevent hypertension and lower blood pressure, and a diet that is sort of Mediterranean-like, which is rich in whole grains, fruits, vegetables, seafood, and lean meats, is preferable to alternatives. And I think the more that we provide guidance that is based in evidence rather than in sort of hypothesis, the more trustworthy those guidelines are going to be. But the reality is those guidelines mean nothing if they're not coupled with systems of support so that people can afford the kind of diets that we're recommending.
Thanks. Thank you, Dr. Navar. Steve Sidney, our Chief Science Advisor, he's posing a question that builds on, I think, the consensus among you as a panel that we should begin with blood pressure management. That's a good starting point. And Steve asks, in the face of declining coverage with cuts to Medicaid and other budget priorities, how can we implement for most people the kinds of primary interventions that require medical care, such as blood pressure management?
That's a vexing question, but I would say there's a significant percentage of people who will still be getting care with employer-sponsored insurance. There's folks who will be getting Medicare care. There still will be people getting Medicaid care. There will be folks who will be accessing free charitable clinics that Anne-Marie Navar knows a lot about. They will also be accessing more federally qualified health centers. And I think maybe a different way of saying that is, how might we assure that irrespective of which clinical care, primary care system is accessed, that the quality of that care aligns with the things that we're saying? That's one thing that we can work on, because there's room for improvement, even while we do the work to find better ways and more ways to pay for the access that those who can't afford it right now can attain. So I think there's two parts to that question. Let's get the systems that are providing care to be able to provide the highest quality care based on guidelines, and at the same time, find the ways to get more people into care. I would say that in the ideal and the optimized world, we would be doing things so well at that quality level that we would have streamlined some of what we do and eliminate, not the good word, be better at providing care for maybe a few more people than we are in the moment. It's really, really a challenge when the funding for access to care is being cut. And I don't have a simple answer to that, except maybe another part of this, but cuts are happening there, is figuring out how we can help everybody have a sense of what they can do to control the factors that they can control. Healthier eating is possible if the food is affordable and accessible. How do we help people identify affordable, accessible, healthy food? Being physically active means knowing where and how you might go about being physically active. I used to say to some of my patients, no joke, they would say, I don't feel safe. I'd say, try 7 o'clock in the morning. The bad people are generally sleeping or just not out at that hour. Not to be flip, but to sort of think about the context that they were in. How do we help people control those things, healthy eating, physical activity, getting plenty of sleep, and not smoking, in ways that they feel that they can manage at least a part of their health trajectory?
I'll just be very
Thanks, Eduardo.
though on this, John. I think it's important for us just to mention that we can do things to help offset the negative consequences, but there will be negative consequences with cuts to Medicare or Medicaid and reduce access to the Affordable Care Act marketplace plans. There is no way for us to offset that. Access to health insurance and primary care is fundamental for cardiovascular disease prevention, and there's no policy that we can make to change that. And while I'm speaking, I just want to mention, I noticed in the chat, Penny Chris Etherton, who is really a national brilliant expert in nutrition, Dr. Chris Etherton.
National treasure.
Yeah, that world treasure really has put a great reference about sort of dietary recommendations from an excellent article that was published in Circulation a few years ago that is really sort of focuses in and distills where there is really consistent data around what is good dietary recommendations. And so for those 172 of you out there, it would be a great quick 10-point read to read that comment in the chat. Thanks, Dr. Chris Etherton.
Thank you, Dr. Navarre. The next question comes from Dr. Navarre's friend, Selena Gore at Women Heart, who says, this is building on the last couple of points, if we believe that 80% of heart disease is preventable, should we not be prioritizing health education in schools and ensuring heart-healthy meals in schools and building habits as early as possible? I'm pretty sure we're going to get emphatic yeses there, right?
That's a simple yes. And I got to serve as Commissioner of Health in the state of Texas. One of the programs that we promoted, Coordinated Approach to Child Health, was a health education program in schools that emphasized more physical activity, healthier meals in schools, but also building into curricula lessons that had the double effect of teaching math, teaching health literacy, teaching reading, teaching health literacy. That's a formula that can make a difference in these times where we're trying to figure out A, life course approaches, and B, what do you do with the infrastructure that's in place when you maybe don't have the resources you would wish you had to be able to do even more?
Yeah. Anne-Marie, I'm going to direct the next question to you, at least to begin. We're down to our last minute and a half here. This comes from Jeff Durthaler, formerly from CDC, now at Bayer. And Jeff asks, can you speak to the pros and cons and facilitators and barriers to shifting accountability for health from the healthcare system to the people? And I'm going to take poetic license here and say, what about empowering people to be more accountable for their own health?
Well, I feel like, the question sort of implies like there's an either or. And I think that really there should be a shared accountability. When patients put their trust in us and come to the health system to receive care, that health system should have systems in place to maximize the likelihood of identifying and treating preventable conditions like blood pressure and hyperlipidemia. And there's many instances where the health system fails. The flip side is it is the person's responsibility to get to the doctor and to show up and to take their medications. But that is something that we can help empower our patients with through effective education, also access to healthcare and insurance. At the end of the day, when somebody ends up with a heart attack, it is the burden is on the patients. It just is often not put on them until it's far too late, because maybe they didn't realize or appreciate the severity and need of that condition. So I think right now what I would like to see is shifting upstream the accountability, not wait for it to be on someone's shoulders after they've had a heart attack, but to make people sort of feel more empowered to intervene on their health earlier. But I think we also do need to hold health systems and physicians and the clinical system accountable for the processes, such that when the people do what we ask them to do, go to the doctor, get your screening, take your meds, that we actually get them to goal. And there's lots of evidence that we fail them again and again and again by not intensifying medications, by not initiating new things, by not ordering the appropriate screening tests. So I think both sides have work to do in terms of sort of being held responsible for what we should be responsible for.
And that's going to have to be the last word. So Doctors Anne-Marie Navarre and Eduardo Sanchez, treasured colleagues, friends, people I admire, thank you so much for participating in the National Forum annual meeting, sharing your insights and your wisdom, as well as your high energy. So we value your leadership and your service. Thank you very much. Now, let's move to session 2, Uniting, We know what works. Let's do it. Many of us have had the pleasure of working in Janet Wright's aura during her tenure as Senior Vice President of the American College of Cardiology, or as Executive Director of Million Hearts, or Chief Science Advisor to the Surgeon General, or as Director of CDC's Division of Heart Disease and Stroke Prevention. Today, we are honored to have Dr. Wright, a rabid advocate for cardiovascular health and a National Forum Advisory Leadership Council member, leading us through this next conversation. Dr. Wright will set the stage and introduce our speakers. Janet, thank you for your leadership and commitment. The floor is yours.
Good afternoon, everyone, and thank you, John, for the kind introduction. I am delighted today to facilitate session 2, Uniting, We Know What Works, so let's do it. This session will spotlight high-impact opportunities and real-world examples that help people make prevention part of everyday life. We'll focus on 3 themes. First, reducing the lifetime accumulated risk by elevating prevention in childhood, adolescence, and early adulthood, starting off strong and healthy. Number 2, preventing linked conditions across cancer, diabetes, heart disease, hypertension, kidney disease, lipids, obesity, stroke, and brain health. And finally, closing the urban-rural gap in cardiovascular and metabolic health. I think diminishing the importance of the zip code so we raise the boats for all and eliminate that disparity gap. Just a reminder, you can submit questions anytime using the Q&A feature. Please send them as they come to mind. We'll collect and curate them for the live Q&A. We're fortunate today to have 3 outstanding speakers, 3 outstanding leaders with us. First, Stephen Daniels, MD, PhD. He's the professor and chair of the Department of Pediatrics at the University of Colorado School of Medicine and pediatrician in chief at Children's Hospital, Colorado. He's going to address early life interventions for prevention and how we can lower lifetime risk starting now. Next, Anand Parekh, MD, MPH, Chief Health Policy Officer and Adjunct Professor in the Department of Health Management and Policy, and Senior Advisor at the Institute for Healthcare Policy and Innovation, the University of Michigan. He's going to speak to preventing the multiple linked conditions through shared and scalable strategies. And finally, Karen Joint-Maddox, MD, MPH. She is co-director of the Center for Advancing Health Services, Policy, and Economics Research at WashU in St. Louis. She's going to focus on reversing the rise in urban and rural disparities with practical models that fit local realities. So first, to kick us off, Dr. Daniels, thank you for being here, and the floor is yours.
Thank you, Janet. The risk for cardiovascular disease is a lifelong risk, as depicted in this slide. We know that atherosclerotic cardiovascular disease is the #1 cause of death in the United States and in many other countries around the world. Historically, it was thought of as an adult problem, but as you can see here, it is a disease process that begins in childhood and progresses throughout life and is largely asymptomatic until the challenges of myocardial infarction and cerebrovascular accident occur later in life. As you'll see on the next slide, we finally have evidence that from the I3C consortium, this is a group of international studies that have shown that risk factors measured in childhood are directly associated with major adverse cardiovascular events in adulthood through cohorts that are followed over the life course. And traditionally, this is how we've thought about this for smoking, obesity, blood pressure, dyslipidemia, as identifying individuals at higher risk. However, in the next slide, as you'll see, Dr. Stamler and others flipped this issue around to show that actually we should probably be focusing also on low risk individuals, those with cardiovascular health, as opposed to cardiovascular illness. And as you can see in the Mr. Fit and Chicago Heart Association cohorts, they identified low risk by low serum cholesterol, low blood pressure, not a smoker, no diabetes, and no ECG abnormalities. On the next slide, we'll see results that I think are amazing, and they show that actually those who are able to maintain cardiovascular health or low cardiovascular risk have a dramatic decrease in cardiovascular disease mortality, all-cause mortality, and even a substantial greater life expectancy. What's interesting here on this slide is that if you look at the Chicago Heart Association men in the younger age group, the greater life expectancy approaches 10 years, suggesting that starting early in life actually can have an even greater effect than starting later in life with cardiovascular health. Next slide. Nori Allen at Northwestern has shown that actually the genetics of ideal cardiovascular health are a relatively small component of this picture. Only 17% can be attributed to genetics, which means that roughly 85% of this is attributable to lifestyle, things such as diet and physical activity. Next slide. So this has led the American Heart Association to present the concept of life's essential aid, as you can see here. And these are the factors that maintain ideal cardiovascular health and reduce risk. And you can see that these are the kinds of things that we should be focusing on from a life course, lifelong perspective. Next slide. So here's how we're doing. This is looking at the health behaviors in children. And if you start with the upper left-hand corner, you can see that with respect to diet, we are not doing very well. You see the bars more to the red than to the green. We do better with nicotine exposure, although this is potentially a later in life exposure. We do somewhat better in sleep health, and again, not quite as well in physical activity. And you can see it broken down here by gender and by age group, and also by race and ethnicity, showing some differences across different populations. Next slide. So what this shows is that we are actually losing a precious resource as individuals go from age 12 to 19 up to age 60 and greater. So you can see in the yellow, greater than or equal to 5 metrics, declining with age. And you can see in the green, greater than or equal to 6 of these ideal health metrics, actually starting low, but continuing to decrease. So clearly work for us to do as we think about child and adolescent health and how it progresses through the lifespan. Next slide. So what can we do about this? I think the key here is that we should be addressing with every child and adolescent and their family issues that speak to, in this case, physical activity. And you can see we should be asking them, how do they spend their day? How much of it is spent in physical activity, and how much of it is spent in sedentary time, so that we may be able to change the dynamic and increase their experience with physical activity. And on the next slide, you can see the questions related to nutrition. We need to understand the patterns of eating and how we can move children and adolescents to a healthier pattern of eating, so that we can have more of our children and adolescents in that healthier category related to diet. I think we can do this, and I think if we continue on that path, we can dramatically improve cardiovascular health. Our job, I think, as pediatricians is to deliver children and adolescents into adulthood in ideal cardiovascular health so that they can maintain that throughout the lifespan.
Thank you, Dr. Daniels. What I really appreciate is not only did you lay out the case but you gave us specific actions that we can all entertain. I don't know if you meant those questions just for pediatricians to ask, but we can ask those in school surveys and in all kinds of offices and in encounters with kids. I've written them down now for my grandchildren. So you've grounded us in what works early and why it matters. As we look beyond these single conditions, our next focus is on prevention that travels across multiple diagnoses. I'm pleased to welcome Dr. Parekh. He's going to share how aligned strategies can reduce the risk for many different conditions, this sort of syndemic idea. Dr. Parekh, thank you for joining us.
Thank you, Dr. Wright, for that introduction. Thanks to the National Forum and John, and great to be on this panel with Dr. Maddox and Dr. Daniels. So the title of my short talk is this very lengthy title. In fact, it's probably the longest title I've had to date. It's provided by the National Forum, but in many ways, the length of the title makes the point. Because if we really want to reverse the cardiovascular epidemic in this country, by doing so, we would also reduce the morbidity and mortality from so many related conditions. And that's because all of these conditions have many, many common risk factors. Next slide, please. So a bit of an orientation in terms of my perspective. I started my public service career first as a clinician and then as a policy expert focused on individuals who have multiple chronic conditions, not just one, but 2, 3, 4, 5, 6, 7 concurrent conditions. And we see so many more Americans with multiple chronic conditions, given the aging of the population, the continued existence of chronic disease risk factors, really the marvels of modern medicine. And so really our initiative at Health and Human Services was to optimize the quality, the health and the quality of life for individuals with multiple chronic conditions. We focused on a number of different goals. And one of the specific projects that we undertook was partnering with clinical practice guideline developers to ensure that clinical practice guidelines on index conditions had information about important and prevalent comorbidities. Next step. And one of the efforts that we undertook was a partnership with ACC as well as AHA, next slide, please, where we looked at some of those most common conditions with common cardiovascular conditions like ischemic heart disease, heart failure, atrial fibrillation. You see here on table 1 some of those most common comorbidities. And then in table 2, you see some of the most common dyads and triads. And so the question of why do these conditions cluster together is in fact what I just spoke about, that the underlying risk factors driving many of these conditions are virtually, next slide, please. And so later in my career at HHS during public service, I focused less on chronic disease management and more on chronic disease prevention. And this is one of the examples of efforts that we undertook working with the Centers for Disease Control and Prevention, focused on getting at those common risk factors outside the 4 walls of the clinical setting. And as Dr. Daniels mentioned, many of these risk factors, like physical activity, tobacco use, sodium, added sugar, and nutrition, are really driving the cardiovascular disease epidemic in this country. And what we found was that if we could take a number of evidence-based strategies, like focusing on immediate counter appetite, or accessibility, or point of purchase, price and affordability, support services, what we could do is really change the underlying systems and environments so that for individuals, the healthy choice becomes, in fact, the easy choice. Next slide, please. That really sort of led to this idea for me after spending time at Health and Human Services, that where we really needed to go in this country was to form a prevention first agenda. And this is very much in line with what the National Forum has talked about, really achieving a prevention first vision, setting prevention as a top priority for policymakers. There are a number of ways we can talk about how to do that. For example, develop quality metrics, and quality metrics or currency that drive value-based healthcare transformation. But we need quality metrics that focus on the incidence of chronic disease and the prevalence of chronic disease risk factors. We need to measure and set targets for primary care spending. As we know, primary care is so critical as the place where a lot of cardiovascular risk takes place. We need to increase per capita public health funding and the important complementary role that has to clinical prevention. So there are a number of things that we can do to achieve a prevention first vision that will also simultaneously reduce morbidity and mortality of cardiovascular. So please. And so a couple of opportunities, I think, near-term opportunities for industry, for health plans, for payers, for health plans and payers, for providers, for health systems, as well as community-based organizations are to engage in public-private partnerships that get at some of these underlying risk factors. Now, we saw for 2 or 3 decades a significant reduction in deaths from cardiovascular disease in this country due to tobacco control and prevention efforts, and then broader cardiovascular prevention and management efforts. But over the last 10 or 15 years, we've seen a plateauing in that decline because of increased or worsening control in all those factors that Dr. Dan has talked about: glycemia, blood pressure, lipid control, alcohol consumption, obesity, persistent socioeconomic disparities. And so the question is, how do we resume decline? And here are just a couple of examples where federal leadership is critical, but really public-private partnerships that get it. For example, sodium reduction. So in this country, we know that we consume too much sodium. We were at about 3,400 milligrams per day. We're at about 3,100 milligrams. We currently have voluntary sodium targets through the FDA to get to 3,000. They've just recently published draft targets to get to 2,750, but they've been working with the industry to reformulate products to reduce tobacco or sodium content in a variety of different products. Absolutely critical. Probably ought to do the same with added sugar. There's dietary guidelines for Americans, but no more than 10% of calories should be from added sugar. We're at about 13-14% population-wide, so 30 to 40% higher than the upper limit. So the same idea, sort of working with industry to reduce added sugars in a variety of different categories. And then on the healthcare side, there are a number of opportunities there, and a couple listed here. So it's the diabetes prevention program, which many of you are well familiar with, evidence-based, intensive behavioral modification intervention focused on diet and exercise, which reduces the progression of prediabetes and diabetes. To give you one example, in Medicare, we have 25 million beneficiaries with prediabetes, yet only a couple thousand are currently actually benefiting from the diabetes prevention program. So how do you scale them? Obesity management. There are a number of evidence-based interventions, from intensive behavioral counseling and nutrition therapy, now pharmacologic agents. How do we increase access to these evidence-based therapies? And then certainly, as Dr. Wright has led for over a decade now, the important work with the American Hearts Initiative and the important opportunity, particularly for blood pressure control, through both provider incentives as well as educating their patients. So I think there are a number of near-term opportunities that get at those common risk factors again, that will not only help us tackle the cardiovascular disease epidemic, but all of those linked conditions that were in the title of my talk. If we can get at those risk factors, then we can really address morbidity and mortality from all of them. And then, of course, what's not listed here is continued focus on tobacco control and prevention that hasn't contributed to the plateauing decline, but there's still much more work to be done. So looking forward to discussing this more in greater detail, but thanks so much.
Thank you so much, Anand. I love the way you bring public health, healthcare, particularly primary care, and policy all in a bundle and focusing out on prevention. It's a beautiful thing to see, and I've seen you in action. So now, in talking about prevention, we know that health begins at home, prevention really begins at home, and in homes in rural and urban environments, we're seeing quite a difference in terms of the disease burden. So Dr. Karen Joint-Maddox, you are here to highlight ways that we can help those communities both raise the bar, but eliminate the gap. Karen.
Thank you. And it's an honor to be part of this group. And I think you'll hear some common themes in what I will comment on today. I'll also say, as an adult cardiologist, I would like to be put out of business by the pediatric folks and prevention folks in the room. But thus far, we've stayed plenty busy. So next slide, please. So the first thing I'd like to point out is that actually rural health inequities are a pretty recent phenomenon and have been widening quite quickly, suggesting that there really is some difference emerging between urban and rural areas that is driven perhaps by access to care and other things that we'll talk about. But really through the mid-1980s, rural and urban death rates were fairly similar. And since that time, we've seen death rates in urban communities continue to decline, particularly in wealthy urban communities, while we've seen a real plateau, as was mentioned earlier, in overall progress in rural areas. On the next slide, you can see that cardiovascular disease and stroke are major drivers of these decrements in rural mortality. You can see where the red areas are sort of the hot spots of cardiovascular mortality, but I'll say again, in reflecting on the prior speakers, you could put cancer mortality, you could put many, many other things in that same map, brain health, dementia, because all of these things are really driven by a set of common underlying factors that are clustering in areas where we see rurality, poverty, community disinvestment, and a number of risk factors come together in particularly vulnerable communities. On the next slide, you'll see a few thoughts about why. So the traditional and emerging risk factors, social determinants of health, healthcare infrastructure, insurance access, quality, and capacity. So on the next slide, we know that in rural areas, traditional risk factors that used to be lower in rural areas are now higher in rural areas. You can see here data on hypertension and diabetes, as well as obesity and mental health, all both worse in rural areas and worsening in rural areas compared to urban ones. I'd particularly draw your attention to obesity and the suicide rates in the bottom right, which I think are areas where perhaps there's not been as much conversation around the change in urban versus rural areas and the degree to which mental health in particular really may drive a lot of commonality among disease increases. Next slide, please. We also know that there's many social determinants of health that are linked to health outcomes that are also increasingly common in rural areas. So poverty, historically, we think of poverty as maybe being sort of the urban poor, but in reality, poverty rates are significantly higher in rural areas, and the resources that people have to avail themselves of food pantries and other support are lower in rural areas. And so you see greater food insecurity in rural areas and actually a growing housing crisis in rural areas as the housing stock ages and community disinvestment grows. On the next slide, we also know that infrastructure is worse in rural areas and again, headed in the wrong direction. So on the left, you can see levels of uninsurance, and you can see, testing my geography here, Texas, Georgia, Florida, Mississippi are hotspots of uninsurance, and some of those places overlap in the same places as we see adverse cardiovascular and metabolic outcomes. And then on the right, health professional shortage areas, and again, you'll see the same overlap of areas where we have rurality, poverty, community disinvestment, where we see access issues in, for example, both hospital facilities and primary care. On the next slide, we'll try to talk about a few possible solutions, though I will say that as a policy person, these sort of can't high. And we also obviously need to think about designing solutions for local areas. But I think unless we think about the policy solutions, we're unlikely to support sustainability in local investment. So we always hear about telehealth for rural areas, and I think that's certainly worth supporting. I will say, however, that the greatest users of telehealth post-COVID are urbanites who are trying to get around a lot of trouble with the inconvenience of healthcare. So telehealth is actually used at about double the rate in Medicare in urban versus rural areas. It is helping close the gap, but it is not in and of itself going to solve the problem. Necessary, but not sufficient. Insurance expansion, you can see there the latest map of Medicaid expansion demonstrating a clear geographic patterns in where Medicaid has not been expanded and where we see the highest rates of uninsurance. We know that children are more likely to be insured up until they reach adulthood, but there's a real cliff around the ages of 18 and 26, where we see children start to enter a phase where they have the highest uninsurance rates right at a key time in life for developing positive cardiovascular habits. And then I think I'd be remiss to not mention the importance of investment in rural areas. On the graph on the right, you can see the recovery of employment in urban versus rural areas post-COVID, demonstrating that urban has essentially recovered and rural is lagging quite a bit behind. Next slide, please. So overall, rural health disparities are large and growing, and cardiometabolic disease is a key driver, both of cardiovascular disease, but again, also of cancer and brain health and dementia and stroke. The causes are multifactorial, and we have to think about both the standard and emerging risk factors as well as social risk, which I think is the most quickly widening gap with rural America. Healthcare access and quality are challenges, and solutions include telehealth, insurance expansion, and broader infrastructural investment. I will also echo the prior speakers in saying that without a national focus on this type of work, local efforts can only go so far. And so I think it's incumbent upon all of us to be able to think about how to design community-informed local programs, but also recognize none of those are sustainable without policy action to make sure that resources can be delivered where they're needed. Thank you.
Thank you, Dr. Joint Maddox, for those concrete approaches to fairness and to access. Each of our panelists has given us a strong foundation for discussion. Dr. Daniels, I'd love to come back to you with a question about how to operationalize those questions that you shared with us. How can we put those into practice, whether we are in public health, in healthcare, in a community-based organization? They're such important questions.
Yeah, thank you. I do think they're the kind of questions that don't need to be just focused in a pediatrician's or a family physician's office. These are the kinds of things that should come across in schools. They should come across in a number of settings where children and adolescents spend their lives and where decisions are made around lifestyle factors, which we know are so important. So it would be great if those kinds of questions and the responses to answers could be happening at multiple venues, multiple levels, throughout multiple ages, because I think these need emphasis and re-emphasis as we work towards healthier kind of lifestyles for children and adolescents.
Thank you. Thank you for that. Those are good marching orders for all of us, wherever we sit or stand. Dr. Parekh, I know your passion for policy and your ability to analyze things that are effective and hone them so they're more effective. When you think about the programs that you led during your department days and even at the Bipartisan Policy Center, are there lessons you could share with us about how to expand or get these things that are well designed, but how to get them more rapidly implemented? What's in the way of the implementation piece? It's always the hard thing.
Yeah, no, I think it's a great question, and my experience is that I think in many ways we know what we need to do. We just need to elevate these issues really to the top of the mind of policymakers and leadership, and align them in a way where it corresponds to their vision. So when we talk about whether it's MAHA or the Children's Chronic Disease Epidemic, we ought to be talking about all of these underlying risk factors that we've been talking about today, whether it's better nutrition or reduced screen time or increased physical activity. And so ensuring that policymakers understand that what we're talking about here not only has a disproportionate impact on the health of the nation, but is very much in line with, frankly, reversing the children's chronic disease epidemic in this country. And so sometimes I think it's making that connection, ensuring that policymakers and healthcare leaders know, and then providing them that menu of evidence-based programs, activities, and I don't think we really need to reinvent the wheel. Certainly, we always need new science and new research, but we know what works when it comes to cardiovascular risk factor reduction in so many of these critical areas. It's more a question of implementing that and prioritizing that. Having the funding for the programs also critical as well. And we talk about some of the concerns and risks in the federal environment, but it's going to be really important to maintain these evidence-based these programs because they're the ones that can lead implementation of evidence-based interventions with the private sector, of course.
You said so much there, and I'm going to ask our other two speakers to weigh in on their thoughts on implementation. I think we'd all agree that's hard, and maybe one aspect that makes it so hard is its sustainability. The sustaining a focus on a particular intervention or set of strategies over time, and that gets at funding. It also gets at what a leader's priorities are. So let me open the floor for Drs. Maddox and Daniels to comment on how can we accelerate the implementation of what works.
I'm glad to jump in on a few policy thoughts. You'll be shocked. I think that we have made such a complex stew of value-based and other sorts of payment programs, and in doing so have really missed an opportunity to use value-based payment to focus on prevention. I think we've seen from the advances, for example, in survival for acute myocardial infarction or stroke, right, which continue to improve, those are doing great. There are financial incentives, there are technologies, there's a lot of momentum behind treating the big, scary acute disease, and we should keep doing that. But where there's sort of a collective action problem and where I think policy really needs to focus is on prevention. That's not anyone's sort of exciting, pricey thing right now that's going to get hospital executives excited. That's what policy's for. The policymakers have to sort of protect the common interest in a way that goes beyond the shiny objects. And that, I think, means really streamlining our approach to payment to focus on rewarding prevention. As Dr. Parekh mentioned, we don't have many things that reward people for reducing the prevalence of chronic disease, right? We really want to make sure everyone gets their aspirin if they have a heart attack. We should keep doing that. But what about not having heart attacks in the first place? We need fewer heart attacks in the first place, and that's not captured anywhere in a way that's really sort of central and meaningful to most health systems right now, particularly in sort of the consolidated environment in which we find ourselves. So that's where I think we need to push.
Karen, I have to jump in, and Steve, I'll turn to you, but I just want to say viewing heart attacks as a failure, like a failed. If somebody had a heart attack, that's a failure. It may not be my failure, but it is a failure of the whole system of prevention and public health and healthcare. Steve.
Well, and I think we could say that it probably is a failure that we haven't put Karen and her colleagues out of business because we really do have the means to do that. I'd like to go back to one of Anand's earlier points, and that is figuring out ways to make the healthiest choice the easiest choice. Because in many cases, it's the exact opposite of that. It's, we have children who every day face this gauntlet of decisions about their lifestyle that are made more difficult than they should be. And we need policy that helps direct those decisions in the healthiest ways. I think the initiative to lower sodium in foods could be incredibly effective. My sense is that nobody would even notice if we did it gradually, and it could have a dramatic impact on health. I think the same could be true for added sugars in a variety of foods and drinks. So those would be the kinds of things that not only would be good in the short term, but I think actually could be quite sustainable.
Let me go back to something that I think each of you touched on, and that is this. I'll say from my own observations, I've heard much more lately about local and state work than federal work, and yet you've each indicated how important it is to have both. Could we go a level deeper on that and talk about what is necessary from a federal standpoint, and how can we fuel further work at a local level?
But well, I can start because I do think that there'll be some mitigation work that's going to happen at the state and local level over the next few years, even likely cuts or presumed cuts to Medicaid, as well as cuts to SNAP. And so when you think about how do we optimize cardiovascular health, if you have more Americans who are food insecure, you have more Americans who are uninsured, as Dr. Maddox mentioned, both through Medicaid or the individual markets. So foreshadow a year, 12 months, 18 months from now, we could be looking at a situation where we have millions more who are uninsured and food insecure. And that's just going to make our job of cardiovascular risk reduction and prevention that much more difficult. And so I think states and localities are really where this is going to play out, and mitigating those impacts in a variety of different ways. State Medicaid programs will be critical. How you use the state rural healthcare transformation fund is going to be absolutely critical as well. How at the local level, even though they're strained, how community-based organizations can be supportive to whether ensure that individuals have a legal source of care or they have access to healthy food. So I do think that at the state and local level in the near term, there's going to be a fair bit of mitigation given some of the federal policies that are coming down its way. Beyond that, I do think that it's really scaling a lot of what we know, but I'd love to hear what the fellow thinks.
Yeah, I mean, I agree with all that. I think to see the importance of local and state action, you only need to look at the map that shows you how different outcomes are already and how many decisions have previously been made to either support health or not support health. And I do think that we have seen, regardless of red or blue, we have seen different states take different approaches to how they think about public health and prevention. And so there ought to be a lot of ways we can learn from this and try to understand. And we do a lot of work with the state of Missouri. And it doesn't do any good for me to go to the state of Missouri and say Massachusetts had a program that did X, Y, and Z. But it sure does to go to them and say, hey, Mississippi came up with this thing. Look at their education program recently, right? I mean, there really are examples where states have been very creative with very specific things. And so states need to learn from each other. The rural health bill is a great thing to bring up. That's a lot of money. And states are really thinking actively about how to use that in prevention. And so we'll have an opportunity for states to learn from each other about what they can do to mitigate, to promote, right, in places where they're doing a pretty good job. So I think it's more important than ever that states are engaged on prevention because they have an opportunity to do something right now.
Yeah, I agree. It does take both. I think what's missing is the conversation about the incredible return on investment by improving cardiovascular health or health in general, because as it turns out, and as Anand showed, it's not just about cardiovascular health, it's actually about overall health and including mental health, which is a clear focus these days. The kinds of lifestyle factors that we're talking about have such people have said, if we were talking about a medication here, everybody would be lined up to take it. And yet we're not really making the case well enough, perhaps, that the benefits and the lifelong benefits are there with these kinds of lifestyle approaches. So to me, we need to figure out how to get people talking that way, as opposed to talking about all the barriers and how hard it is and et cetera, because it seems like these are problems that can be solved.
Steve, it's kind of scary. I had just written on my little yellow pad here as a final question for you all. We'll make a lightning round. I'm going to warn you about what that question will be. Well, I'll tell you what it's going to be. It is the business case for prevention. To make your pitch as the business case for prevention, imagine you're talking to decision makers. So I'll give you time to think about that, because I'm going to go back to Karen with a question about rural health and specifically rural telehealth. because when I first saw that statistic, it surprised me a bit. And I'm wondering how broadband access is wrapped up in that finding, or what are the other factors that do we know why urbanites have adopted telehealth much more rapidly than rural folks?
We don't know exactly, although I'll say it's been seen in a number of studies that post-COVID adoption in rural areas is lower. Part of it is internet access, although for most of the US, there is decent internet access. So I don't think that's the whole story. It certainly is in pockets, but I don't think it's the whole story, because you see small towns down there also, and they typically do have, better infrastructure than true sort of remote areas. I think part of it is cultural. And I actually think part of it is that people are using telehealth to connect with their local providers. So if there's an absence of local providers and an absence of local infrastructure, you don't have the people on the other end of the telehealth, if that makes sense.
Yep.
It's like how you can, if you know somebody already, you can have a Zoom call with them and feel very comfortable. But if you don't, it's kind of weird. Body language and sort of how do you work in a group? And I think that for people who may lack the opportunity to connect with a range of clinicians, telehealth doesn't fix that problem. It's a good way to stay in touch. I don't think it's a good way to establish relationships. And so I think we need to think about a combination of strategies to make that more effective than just sort of, here's the internet.
I was surprised with how much coaching an individual needs to do self-measured blood pressure monitoring. You can give them a handout on how to use the device, but transmitting those readings to a clinician, people need someone to coach them. And Steve, I saw your head nod. You agree, or do you or Anand have other comments about the rural-urban divide and telehealth use there?
Well, one of the things about telehealth that I think might be underutilized, and I get information from our dietitians who do telehealth, and they actually really like doing telehealth with the patient and their family in their home setting, because it allows them to get a better sense of what that home setting is really like, and perhaps make more informed discussion about how changes could be made. And I think that probably applies across urban and rural settings, and may actually improve our understanding of the different settings that patients find themselves in. So to me, it seems like, we learned a lot about telehealth related to COVID, but there's still a lot of things both on the positive side and potentially on the negative side that we need to work on.
Great. Steve,
Yeah,
how's that visit paid for? Sorry, none. How's that visit paid for?
Well, under the emergency order for COVID, it was paid for, and it worked out really quite well. So to me, it seems like, the answer is obvious. It needs to be paid for, and it needs to be, in our case, it's probably true of Karen too. We work across state lines, and so it really has to be available to have that kind of dynamic to make it work effectively.
Yeah. Anand, sorry I interrupted you.
No, I was just going to add that on the telehealth side, this is another one in the mitigation category. Hopefully we'll see a resumption in flexibilities for telehealth. Hopefully these will become permanent to allow increased telehealth use, at least particularly in the Medicare population. But also a lot of these communities still don't have broadband access. So there are a number of policy issues I think that can be important.
Well, and I just say it seems to me that we need more implementation, dissemination type science around telehealth to understand its strengths and weaknesses better.
And just to throw out a term that somehow we've not anchored on so far, we need team-based care. We've all been saying it without saying it, but really telehealth is the perfect way to engage a wide range of clinicians and support and all of the things in a way that you can't necessarily do all in one place all at one time. And so it really is sort of the facilitator for some of that excellent sort of high touch kind of work that you really need when you're helping someone, use a blood pressure cuff and figure out what the right medications are. That should not be once a year you come in, drive in, see your doctor, fight the traffic. That cannot be the model for how we deliver care, urban or rural. And so if we can do telehealth with team-based care, we could do so much more high touch that currently is not reimbursed, that's not valued, and is, we're getting what we're paying for, essentially, which is yearly visits for hypertension.
Karen, I'm so glad you brought team-based care up. Anand, when you were speaking, I was thinking about, cardiovascular health or disease prevention as the gateway for these other conditions. Because when you pull teams together, when you have a team and you have some technology that works for the patient as well as the clinical squad, and you've got timely data, you can make good decisions. So all of those things, we're talking about them primarily for heart disease and stroke prevention, but they do apply to diabetes management, to obesity, to mental health, definitely mental health as well. So getting those things out there.
It's interesting. When we talk about disease, we tend to talk in silos. When we talk about prevention, it seems to me we can talk in a joint way that can work across all of our subspecialties. So we need to think about how to organize around that better.
And start early, right?
Yep, as early as possible.
Yes. Well, I think it's time for the lightning round. It's lightning only in that you can take as many minutes as you'd like, but imagine that you are making the case, the business case for prevention, and you can do it either with the environment we're living in right now or your dream environment. Hopefully keep it somewhat reasonable, reachable through policy change. So who would like to go first?
Well, I can start off by saying that, we always say that good health is good business. And so much of cardiovascular disease screening and prevention is, if not cost saving, at least it's cost effective. And we know from a value perspective, so highly. We all know that when you talk about prevention, the reason you ought to focus on prevention is for better health outcomes. It's not to save money, but in many cases, particularly when it comes to cardiovascular disease, it's safe. And so I think, everyone who is attending today, know that there are opportunities with businesses in your community, state Medicaid programs, state employee health plans. There are opportunities where if these entities will elevate focus on cardiovascular risk factor reduction and prevention, that not only will they have healthier employees, but they would also save dollars for business, the Medicaid program, if they any type of care, healthcare. So it's a double benefit here, and I think you're right. We ought to talk about it more, in that construct.
Yeah, it seems to me that there are some challenges in making this case because oftentimes we're talking about things that didn't happen, and that's an outcome that is hard to express.
Right.
I know in the hospital setting, we now talk about injuries that didn't happen to children because of preventable harm. And I think maybe we can start to talk about these kinds of disease outcomes in the same way. But to me, the increased longevity and increased morbidity-free longevity is the thing that makes the case. That I think everybody wants and everybody can understand. The hard part there is, in many cases, as you talk to insurers and policymakers, et cetera, their interest is in short-term outcomes. And this is a case where we have to make the case for a long-term outcome, a really good one, but one that takes a lifetime to see the benefits for. So I think the case, I'm biased, I guess. I think the case is obvious, but it's one we have to really continue to explain in ways that people understand it and can then play out in various healthcare environments.
Yes, Steve took the words out of my mouth. I was going to say I'll take the flip side of the life course from the pediatric population and say that Medicare needs to invest in prevention, because Medicare gets all of us, right? We have sort of a societal agreement that at a certain age, we are all going to be taken care of by the government. So, hey, government, let's get a lot of really healthy 65-year-olds aging into Medicare and still being productive, and also being able to play with their grandkids and do the things that they want to do, but also having a longer, more sort of productive, adult life is something that everyone wants, and something that actually is economically positive, but you can't create that starting at age 65, right? And Medicare should be incredibly incented to push on prevention, because they get all of us. If we're lucky, it's a privilege to age into Medicare, right? And so they really ought to be the ones thinking broadly about how they can partner to get healthy.
Yeah, we would love for Medicare to think pediatrics. Good concept.
You heard it here first. Well, I think those are words of wisdom from each of you. During the discussion, I heard, how can we make prevention what the cool kids do, one form or the other. And because there is a big table at which that is set for many different types of organizations that are necessary in order to prevent heart disease and stroke, right? So we really have business cases for community-based organizations, for mayors that are now moving with the National Forum, and then federal agencies, certainly CMS leading the way in Medicare and Medicaid, and private payers, and then a whole slew of clinicians sweeping across primary care and pediatrics to those taking care of folks at older ages. And so breaking down that business case and making sure that the policy solutions advantage all of them, or at least keep them above water and don't disadvantage any, that is quite a puzzle. But I know that the National Forum hosts large collaborations, large and small, and can help us move the needle on this very important thing, and then spread the lessons learned to those other conditions. So on behalf of everyone here, I want to thank our speakers for clear, actionable insights today. We're going to now move into the Q&A. Please continue to send your questions through the Q&A feature. And I'm pleased to invite John Clymer, Executive Director of the National Forum, to facilitate the Q&A. John, over to you.
Thank you very much, Janet Wright, and Drs. Daniels, Joint Maddox, and Perek. Today's a travel day for Dr. Wright. We're grateful to you for fitting the panel discussion in, and we understand that you can't stay with us for the Q&A, but our terrific panelists are here. So as Janet said, please use the Q&A feature at the bottom of your screen to ask questions. I want to begin with a comment. I love the idea that you all hatched, that we should view a heart attack as a failure and strive to stop the failures. Janet is a fan, I know, of Hattie Reese-Hanley from the Right Care Initiative, who poses a related question, which is, how do we flip the script and stop accepting the deadly status quo? Who wants to start with that?
I'll start. I think part of it is events like this and getting a bunch of people together to say this is deadly. We cannot continue down this path. I think there's been a lot of emphasis put on chronic disease in the last 6 months, and we need to leverage the moment to try to figure out how to raise the opportunity to really attack chronic disease right now, particularly trying to prevent those cardiovascular events. Now, we can certainly talk about all of the barriers that are being put in place to those to that attack on chronic disease currently. But we have an opportunity right now to continue the momentum of the push toward chronic disease to try to keep it moving forward.
Thanks, Karen.
Well,
I don't know
John,
if you've seen
I
yet.
think you're going to know what
go
I'm
ahead,
going to
Steve.
say, but it has to start with kids. We have to start early in life, maybe even in utero, to create this healthy pathway. And I think that we don't invest enough in child health, thinking about the return on investment that we get in terms of life course health. So I think there, as we talked about, should Medicare be thinking about prevention that extends to the pediatric age group? Yes, I think it should. But as a society, we need to think about how to make these kinds of investments.
Yeah, and John, I'll just combine both of those comments from Dr. Maddox and Dr. Daniels by saying that, what is topical right now, making America healthy again ought to be making America heart healthy again, and reversing the chronic disease epidemic. To really do that, you need to address the risk factors that we've been talking about today. So I think it's really prioritizing this. I'm so pleased that you had Dr. Oz here to join us, because CMS is such an important entity, perhaps more important than any entity when it comes to population health, and the levers it has through its innovation center, through payment policy, through its quality improvement organizations are so important. And so really getting this not only on the radar, but ensuring that policymakers and leaders understand that this is absolutely critical to their agenda. I think that is sort of the moment that we can't afford to lose right now.
Yeah, absolutely. And the emphasis there and on that the MAHA movement has on child health, early intervention, certainly supports the prescription that all of you have been giving, that Steve has been dispensing for decades. I don't know if you all saw, but this is apropos of Janet's question about the business case. This morning's Wall Street Journal reports, and I'm quoting, "The cost of health insurance rose steeply for a third year in a row in 2025, reaching just under $27,000 for a family plan." And the journal says higher spending on chronic diseases, weight loss drugs, and hospital bills helped drive the increase. So cardiovascular, Anand, this kind of goes to your reference to that extremely lengthy title that we gave you. Cardiovascular, metabolic, kidney, and other chronic diseases are cost drivers as well as killers. And we need to do a lot of things to reduce the chronic disease burden, but it seems like actions often stall because there are just so many levers out there, or there's such diffusion of effort with so many hands pushing and pulling different levers that the effect is diffused and really almost nullified. So if we were to concentrate our efforts, everybody who's participating in this meeting, if we were to concentrate our efforts on just one or two changes, where would you start? I'm going to start with Anand, because I know this is something you've thought about a lot. It's kind of at the root of prevention first. And then Karen and Steve, ask you to comment as well.
Yeah, I think that there are a couple of really important population health initiatives that I talked about. I think sodium and added sugar is really where we need to focus. And then on the clinical front, again, we have some initiatives. Diabetes prevention program has been brought up a number of times already today. The important work of Million Hearts and blood pressure control obviously has been brought up today. So we need to implement those interventions at a clinical level and scale them, the ones that we work, that we know that work. And then at the population level, we need to focus on these broader issues that sort of no one provider or payer can take on their own. So again, I think it's going to be ultimately looking within and outside the four walls of the clinical setting. It's going to be that combination of population health initiatives and clinical care initiatives that we really need to elevate and get both the public and private sector aligned.
Karen, would you affirm that, or would you do anything differently?
I'm just going to add on because I think that the public health stuff, absolutely. And I know that Dr. Daniels is going to say focus on kids. So I will add one, which is to say, we really need to guarantee access to healthcare for everyone. And our healthcare system is too expensive. It is not reasonable for people to pay $27,000 a year for health insurance. That's an insane amount of money. People cannot afford that in this economy. And lots of people are going to go without health insurance. And Medicaid is going to be cut, and even more people are going to go without health insurance. And the people that are going without health insurance are the people whose cardiovascular health is at the tipping point, right? It's people who are in young adulthood. It's people who are on and off of, gig work as Uber drivers or as delivery people. It's a whole bunch of people at incredibly high risk. And we cannot continue to rely on this system of patchwork healthcare systems and patchwork insurance and think that we're going to make any progress on population health. We are fundamentally unable to provide a system of care, either in healthcare facilities or in healthcare coverage, the way that the system is set up. Now, that's a huge thing to take on, so I know that's unfair, but I'm still just going to put it out there as just fundamental to how we think about population health.
Yeah, and you just got props from Madeleine Ogani from Emory and Grady, who said she strongly agrees with prevention across the life course.
Thank you,
That's the key to making America heart healthy.
Amazing. So right back at you.
Steve, prevention across the life course.
Well, yeah. And, John, I think a really important point here is that we're paying for things that are preventable. And so, we need to really flip the script in terms of just accepting that as a concept, which will increasingly become more and more expensive, and really focus on something that Anand has said, which is, how do we make the healthiest choice the easiest choice?
Yeah.
How do we work with, and this is really schools and government and industry all need to be working together to focus on how we can implement these lifestyle changes and how we can create the kind of lifestyle behaviors that ultimately will prevent these illnesses and save us all lots of money.
Yeah, great points. We all know that there is abundant evidence showing that tailored pharmacist services move the needle significantly in the right direction for health, and that they're cost effective. And yet there are all kinds of barriers to people taking advantage of those and to society gaining the benefit. To your point, Steve, about paying for things that don't make sense. So Jeff Durthaler said in the chat that we need universal access to evidence-based clinical pharmacy services. And Karen, Ben Blummel from the APHA Foundation told me that earlier this month, Dr. Oz told the Aspen Institute he believes that advancing the role of the pharmacist is essential for rural health transformation. What say you?
I completely agree. I think, rural health may actually be a place where we learn a lot in the next couple of years, because there's going to be innovation and creative thinking around how to do care better. And fundamentally, we can all learn from what that looks like. And I think what we're likely to see with the rural transformation money and with sort of a shift in thinking around rural health is moving more toward health hubs that are stable, funded infrastructure hubs, as opposed to relying on sort of fee-for-service, pay-for-knee replacement type of work, which is just not how you can fund prevention. And so if we think about rural health as maybe an opportunity to innovate, that has got to include team-based care. It has to engage schools which in rural areas are some of the best infrastructure that we have. And so I think there's a lot of creative ways to think about partnerships with FQHCs in schools, think about rural health hubs, think about technology, and we'll see what we learn. But I think team-based care is central to all that. And actually, pharmacy, community health workers, nurse practitioners, therapists, there are huge opportunities to really train workforce in rural areas as well, in a lot of these areas that are really sorely needed.
Thanks, Karen. Now, I'm going to shift to a related and I mean, there's no beating around the bush. This is a politically indelicate question, particularly since I'm posing it to three people who have MD after their names. But it's a major factor. Karen just talked about team-based care. We've heard other people talk about it, other panelists, you all. We know it works, right? We know people benefit. We know it's efficient. And yet we hear over and over from the medical guild that it has to be physician-led team-based care. That's the only model that they find acceptable. And at the end of the day, when state policymakers are considering models, reimbursement policies, or scope of practice policies that would make team-based care easier for people to access, it's often the medical guilds who get in the way to protect the status quo. So how do we change that? How do we move forward so that, I mean, I know you all embrace team-based care and people's access to evidence-based care. How do we get the rest of physicians on board with that?
Well, and John, I think it's important to say that, different people can look at teams differently. I think the concept that every healthcare team needs to be led by a physician is a ridiculous concept. And one of the things that I think we don't do very well is, while we're working more and more to deliver care in teams, we educate in silos. So we need to transform our medical education environment in a way that we actually are educating in a team-based, interprofessional kind of way. And I think we, by doing that, could actually really enhance the ability of teams to work better together, but also enhance the understanding of what the various roles are that people can bring to these teams, and emphasize people working at the top of their scope in a way that ultimately produces the best result.
Yeah, I'll just add that I think when it comes to medication therapy management, particularly for cardiovascular risk reduction, there really shouldn't be any opposition. Now, I know sometimes there are turf wars and things like that, but really states, and I think a lot of the action is at the state level, scope of practice and reimbursement should facilitate pharmacists performing medication therapy management. And again, a lot of the medications we're talking about here, frankly, are generics. They've been around for a long time: antihypertensives, lipid control agents, anti-diabetic agents. Every time we can sort of reiterate, reaffirm, ensure that patients are hearing the messages about adherence and cardiovascular risk reduction, the better. So this is something that I think we all need to come together on and embrace.
Yeah, you both said it more politely than I would have. I think it's a ridiculous argument. There are so many people who need care. There are so many people who don't have access to care. There is plenty of work to go around. We can all work together, and we need to focus on keeping people healthy. That is our job, right? Not fighting with each other. And I don't know exactly how to get around that, but I will say that I don't think that the guilds represent actually the majority view of physicians in all cases. And I think it is changing with time. Team-based care is becoming much more the norm. It is much more in training already. And I think that this is changing, and I hope will continue to change, and we should all push to continue to change it.
Yeah, I'll just add that, we talked before about really having to work across state lines. Unfortunately, I think the guilds contribute to this state-based sort of protectionist view of how we deliver care. And I think we need to get past that. We need to think more globally and be able to move across those barriers.
Wow, a lot of big picture thinking here. Thank you. We have a lot of questions, so I want to keep this moving. Darwin Labarth asks, do we have to invent a new care or payment or community model, or are there successful models we could implement now? He mentioned that Don Lloyd Jones referred to Finland's North Karelia project. We know that the North Karelia project slashed cardiovascular disease mortality and added 7 years to life expectancy. And Don also mentioned the success of the Cardiovascular Public Health Initiative in rural Franklin County, Maine. And that initiative raised blood pressure control and cholesterol control by, I think it was 25 and 29 percentage points, respectively. Now Greece has what appears to be a successful new initiative underway to effect a shift from this norm of I go to the doctor when I experience symptoms to I go for preventive care. Do you all hear people talking about, are you talking about these or other successful models? Are there some that we should look at as a beacon on the hill?
Well, we've been talking about or lamenting the fact that we have a sick care system for many, many, many years now, and hoping that we'll move to a healthcare system. But we are still very much in the throes of a system that we access only when we are ill or quite ill. And so I think what you're talking about, John, is how do you flip that so people view the system as a system to support them in disease prevention, health promotion. And that is sort of a fundamental shift. Now, I think on the healthcare payment side with value-based healthcare transformation, we talked about this a little bit, but getting the metrics right to incentivize providers to not just manage cardiovascular conditions, but prevent them in the first place. I think there needs to be much more focus in that area. And then on the patient side, as we've talked about, much more facilitation. I think the education piece on both sides is important, but most people understand what they need to do, but they need some support or assistance, whether it's accessing healthy foods or getting generic medications or getting access to care, which is a critical point. And so I think that's really where we need to focus. I don't think that there's some magic payment or delivery model or something new. Again, we know a lot we know what we need to do for the most part. We know what works. We need to facilitate the pathway for patients, and we need to better incentivize providers so that they can provide the care that they want to care, but the system doesn't always facilitate that.
Yeah, so John, I'd like to comment from a pediatric perspective. I think that most people don't seem to recognize that of the majority of pediatric patients are actually covered by Medicaid. People don't think of Medicaid as a pediatric healthcare finance system, but in fact it is. And I think it's problematic because Medicaid is a state-based program, which means that we have kind of an archipelago of different ways of financing child health, when in fact we need a more unified way, because that's the way we could create more efficient and effective systems and get better health, I think, for a lower cost. So my view is that we need to think about changing the healthcare system for children and have a federal Medicaid program focused on kids, rather than having children and pregnant women wrapped into a bigger Medicaid system that tends to break down in a number of ways. So I actually think we could get to a much better place if we started having these kinds of conversations.
Thanks. Karen, we're down to 4 minutes, so I want to move to the next question and ask you to answer it first. Dr. Bill Baumer says we may have to close 200 to 700 rural hospitals in the US because of the loss of rural hospital subsidies. How can we financially support rural hospitals? Karen, you referred to the rural health bill and also about the collective policy problem of prevention, needing to reward prevention more. It seems like a lot of these tie together. And is the rural health bill part of the solution? And if so, how? What else do you see out there?
Yeah, the rural transformation money is not going to make up for the lost money in Medicaid and other subsidies, according to policy analysts. We'll obviously have to see how it plays out, but it will help facilitate some stability in rural areas. And that'll differ quite a bit by state because the way the money is divided, that half of it is divided evenly across 50 states. And obviously states are very different in terms of their population. So in some states that money is going to go a lot farther. And the other half will be divided competitively through a formula that has been released, but is a bit difficult to see how it'll play out. So there's a lot to keep an eye on through applications are due in a couple weeks and the money will be awarded at the end of the year. So a lot to keep an eye on in rural health. I think some states have gotten ahead of this. So Pennsylvania, Missouri, a few other states have done, Maryland have done work to try to stably fund rural hospitals by saying basically you all can't live and die on fee for service and you get one sick patient and you're bankrupt, like let's just fund you. And those have been successful to some degree. They haven't seemed to improve quality or outcomes much, but they have led to some financial stability. And I think the rural emergency hospital program, which also is sort of puttering along where hospitals can voluntarily convert to emergency status only, but get, again, stable funding, is another existing mechanism where we might see some movement. So I'd say there's a lot of solutions on the table, but people have to be willing to fund rural hospitals completely differently than they fund other ones. And I think this moment in time with the bill is actually making states have that conversation. So I suspect we'll see a lot in the beginning of 2026 around trying to stabilize those hospitals is crucial.
Thanks, Karen. I think you just added significantly to many people's insight on that. So thanks.
Well, and John, I think
we're
it's
down to
important
the
say
last
that
minute. So
children's
Steve,
hospitals are also vulnerable to the same risks as rural hospitals. So, because of the Medicaid base, we really need to worry about children's hospitals too.
yeah, absolutely. And that's coming from the perspective of someone who is serving kids from all over the state. Yes?
Yes, and we live this every day. And, I think some of the things that are looming out there will have very serious negative implications for children's hospitals around the country.
Yeah. Thank you. Anand, final word.
Well, I think this conversation is just so important. And, one of the things that, that I'll just mention, obesity, I think as something that we all need to also sort of keep centered, because it is really the rise and prevalence of obesity as the prevalence of tobacco use has come down that has contributed to where we are in terms of cardiovascular disease and all the risk factors, whether it's lipids or sugars or blood pressure. And again, looking at food, environment, and health, clinical community interventions, those underlying risk factors. So obesity on the childhood side as well as the adult side, obviously critical to this conversation as well. So just wanted to make that point.
Thank you very much. Steve Daniels, Karen Joint Maddox, Anand Parekh. Wow, terrific conversation. Thank you. All of you have certainly added to my insight, and I suspect for many of the National Forum members and participants who are with us today. So thank you very much. We appreciate your participating in the meeting as speakers. And I also appreciate all the great comments and questions that people have been posing and putting into chat. Thank you, Jen Childress. We're now ready for session 3. I'm excited to have Juliana Crawford, National Executive Vice President for Emerging Strategies at the American Heart Association and a National Forum board member, as the moderator for this panel. She'll frame the session and introduce our speakers. Juliana, thank you for leading this important discussion. The floor is yours.
Okay. Okay, well, I will start by introducing our panelists. First off, we have Dr. Yvonne Commodore Mensah. Dr. Commodore Mensah is Associate Dean for Research at Johns Hopkins School of Nursing and Johns Hopkins Bloomberg School of Public Health in the Department of Epidemiology. Next, we have Dr. Ann Carroll Goldberg. Dr. Goldberg is a professor of medicine at the Washington University School of Medicine. And then we have Dr. Rashmi Shah. Dr. Shah is adjunct professor in cardiovascular medicine at the University of Utah School of Medicine and also a clinical research scientist at Meta. And then finally, we don't have Dr. Michael Knight with us live today, but we have pre-recorded his session. Dr. Michael G. Knight is Clinical Associate Professor of Medicine at the George Washington University. And we'll begin by hearing Dr. Knight talk with us about obesity in his pre-recorded discussion.
Thank you. I'm excited to really discuss how obesity plays a role in this conversation. As we all know, obesity is a global public health crisis affecting over 650 million adults worldwide, but we also know that it's much more than just numbers on a scale. Obesity is a chronic, relapsing, multifactorial disease that increases the risk of several serious health conditions, some of which we've already heard in our panel. Whether we're discussing cardiovascular disease, we know that obesity contributes to hypertension, atherosclerosis, and heart failure. And we know that it's not just the metabolic process, but we know that there's levels of inflammation and lipid abnormalities that are playing a role here. Type 2 diabetes, which many times their term is called diabesity because of the close correlation to patients who are struggling with type 2 diabetes and living with obesity. Obesity is the strongest risk factor. About 90% of people with type 2 diabetes are overweight or living with obesity. We know that adipose tissue increases insulin resistance, disrupting the glucose metabolism. And so addressing diabetes often goes hand in hand with addressing obesity. And finally, chronic kidney disease. We know that the direct and indirect contributors to kidney damage is related to living with obesity. And then, of course, diabetes and hypertension also involved. So when we talk about addressing cardiometabolic disease, obesity has to be a part of the conversation. But where are we today? We know that there are a number of strategies to treating obesity effectively. But what we know is that a comprehensive strategy is what we use to see success. The foundation of that strategy is diet and physical activity, lifestyle changes. No matter what new medications we have, lifestyle is still the core. And so when we think about whole food diets, caloric restriction, sustainable physical activity, and really thinking about how we interact with food and how we interact with things like super processed foods or foods with poor nutritional quality, we know that that is core to that work. But then we also know that for the majority of patients, over 94.5% of patients who want to achieve long-term weight loss, and specifically those living with obesity, class 1, 2, and certainly class 3 obesity, that's not where the story ends. So additional interventions such as medications. We now are in an era where we have highly effective medical treatments that work to supplement, right? Not replace, but supplement lifestyle interventions. And so whether we're talking about the most recent GLP-1 receptor agonists that like semaglutide or tirzepatide that really lead to 15 to 20% or more of total body weight loss, significantly improving metabolic health. But we also are starting to see weight independent effects on things like cardiovascular disease risk reduction and also liver health. Particularly with MASH. We know bariatric surgery still is a part of the conversation for many patients and improves or resolves type 2 diabetes, reduces cardiovascular mortality, and slowing kidney disease progression. But what does the future hold? We will continue to see highly effective medications with 25% or more total body weight loss. We know that technology, whether it's AI, wearable apps, AI coaching, are going to make obesity treatment more personalized and support lifestyle interventions, but also policy and prevention. So how do we do that early intervention for our youth? How do we prevent obesity? And how do we have coverage for patients, particularly those who are most in need for these treatments? So again, a holistic approach is key. It's more than willpower. It's a complex interplay of biology, environment, and behavior, and combating diseases like diabetes, cardiovascular disease, and chronic kidney disease cannot be done unless we address obesity as a root cause.
Those are great points, a great introduction to obesity and how the interplay with cardiovascular disease. And certainly we know how much of a risk factor diabetes is for cardiovascular disease, and you tied that together with obesity. So thank you for that great overview, Dr. Knight. We're at a moment right now, I think many of us in cardiovascular disease and certainly in prevention feel like we're constantly struggling to get people's attention on the opportunities to prevent the leading cause of death, heart disease and stroke. And often it's because there's some shiny new object out there that has everyone's attention, and it's pulling that attention away from this huge opportunity to prevent cardiometabolic disease. Now, though, GLP-1s, which you mentioned, they're part of the reason why there's intense attention on obesity and weight loss and how it connects to other facets of health. And I'm wondering what your thoughts are on how we can seize this moment to increase the attention on and enable more people to benefit from these innovations and from the new attention on obesity as a way of also preventing heart disease, stroke, diabetes, and kidney disease, which you mentioned.
Yeah. So I think one of the ways that I think about this is I think about residual risk, right? So we know we have effective treatment regimens and recommendations for a patient who has cardiovascular disease, whether it's atherosclerosis, they've had a MI in the past, they've had a stroke. We know the statin therapy to put them on. We know the aspirin to put them on. We know those other medications, but there's still a level of residual risk that is there for our patients. We can all think about a patient that we've gotten them on the full treatment regimen, and unfortunately, they have either a poor outcome from the original event or a recurrent event, whether it's a stroke or a heart attack, that lead to poor health outcomes. So obesity is a large piece of that residual risk. And so treatments like GLP-1s that can not only reduce obesity, but also may have a weight-independent effect on reducing cardiovascular disease can further reduce that residual risk. And that, again, gives us more tools in our toolbox to reduce and improve overall cardiovascular disease outcomes.
So, Michael, we know there's not only attention, but there's really high demand, consumer demand for the semaglutide and tirzepatide. And yet I wonder, is everyone who could benefit from it getting it? Are they able to take advantage of these innovations? And if not, what could we be doing so that everyone who could benefit has access?
Yeah, so unfortunately, no. We know that the majority of patients living with obesity are not getting a treatment. Less than 3 to 5% of patients living with obesity are being treated. And so that's a combination of factors. There's access, so insurance coverage, cost. We know that many of these medications are high cost if they're not covered. And even with coverage, the copays may be very high. So addressing the cost, access, advocacy. We know that, for example, Medicare does not cover treatments that are specifically to treat obesity. And so how do we evolve that thinking that this is not a cosmetic issue, this is a medical issue, to open up access? But then even when you have access, healthcare providers have to also be on board and not waiting for a patient to deserve treatment. right? When a patient shows up with elevated blood pressure, I don't say, well, I'm not going to treat you because you just had that high salt meal last night and you don't deserve the medication, right? It's a part of a comprehensive strategy. So yes, I'm going to counsel you so that you're not having those high salt meals, but I'm also going to treat you. And that same approach is needed in obesity.
Wow. I wish we could have a whole panel on what you just said, because the role of judgment, judging patients, is so important as we wrestle with gaps in care between various populations. But let's hold that for a different briefing or a different convening. Right now, I'd like for us to look out on the horizon. We have these really powerful GLP-1s available today by injection, and we know that in the not too distant future, there probably will be oral versions. They're in the R&D pipeline. How will that change the environment, and how might they change the landscape for obesity and heart disease prevention?
Yeah, well, the benefit there is that we offer more options, right? There are more options for patients. Obviously, there may be some patients that prefer to have an oral agent, so you have that opportunity, but hopefully cost is also going to be improved. We know that there's a supply and demand, right? And so as we have more options, we're hoping that we see the price come down. So I think that if oral options are more accessible and affordable, but also aligned with patient preferences, we're going to see much, much more opportunity to treat obesity and reduce cardiometabolic disease.
And what role does patient preference play in outcome success?
Yeah, it plays a big role because obesity is a chronic condition. This is not a one and done. Many of these treatments are chronic treatments. And so it has to be something that makes sense to the patient long term. It's not, I'm just going to do this for 6 months and then I'm going to go back to what I've been doing. So if they have to be comfortable with administering these medications, with making these lifestyle changes, with having a new approach to physical activity and diet that they can maintain long term. And that is why patient preference is so important. It's not a one size fits all. I have to listen to the patient, understand what their values are, understand what is workable and sustainable for them, and then come up with a comprehensive treatment plan that makes sense. So that patient partnership is so important when we are treating chronic disease.
Dr. Michael Knight, thank you very much for an informative and dynamic presentation and conversation. Now we'll turn the microphone back to Juliana Crawford and the panel.
Okay. All right. We're going to begin with Dr. Commodore Mensah, who's going to talk to us about hypertension.
Good afternoon, everyone. It's such a pleasure to be invited to provide an overview of the most recent 2025 high blood pressure guidelines. First, I'd like to acknowledge that this work was done by 29 clinicians, 4 clinicians, and in collaboration with 13 different societies focused on the prevention, detection, evaluation, and management of high blood pressure in adults. Here's the problem. Unfortunately, approximately 120 million Americans have high blood pressure. We also know that high blood pressure is a leading risk factor for cardiovascular disease, stroke, kidney disease, and there's so much more we can do to control blood pressure. Now, we know that according to national data from the National Health and Nutrition Examination Survey, less than 1 in 4 U.S. adults have their blood pressure controlled to less than 130/80. This is a problem because we know that controlling high blood pressure prevents cardiovascular disease, stroke, and kidney disease. In the most recent 2025 guidelines, we have more evidence that controlling blood pressure is linked with brain health. So in 2017, there's a recommendation that blood pressure lowering may be reasonable to prevent cognitive decline. However, in the 2025 guidelines, we have stronger evidence that in adults with hypertension, a goal of less than 130 systolic blood pressure is recommended to prevent mild cognitive impairment and dementia. So now we have another reason to control blood pressure even more strongly. So the take-home message here is intensive lowering of blood pressure reduces the risk of cognitive decline and dementia by 15%. Now, when it comes to controlling blood pressure and managing blood pressure, there are things that we need to consider in terms of treatment thresholds and the goal. One thing that is unchanged is the fact that normal blood pressure is still considered less than 120 and 80. So systolic blood pressure has to be less than 120 and the diastolic has to be less than 80 to be considered normal. A new addition in the 2025 guidelines is the use of the PREVENT equation, and I'll talk more about that in the subsequent slides. However, the goal for blood pressure control for adults with hypertension is less than 130 millimeters of mercury, but a new addition is that it is encouraged that in adults who can tolerate more intense blood pressure control, we should be treating blood pressure to a goal of less than 120 millimeters of mercury. Now, this is because we have more robust evidence that intensive blood pressure lowering reduces the risk of cardiovascular disease, kidney disease, and as I mentioned earlier, cognitive decline and dementia as well. In managing blood pressure, we also consider an individual's risk for cardiovascular disease. One thing that has not also changed is that lifestyle modification is a hallmark of blood pressure control. So for all adults diagnosed with hypertension, we need to focus on lifestyle modification, but also in preventing hypertension in the first place, lifestyle modification is effective. For individuals with stage 1 hypertension, we need to use the PREVENT equation, which estimates the 10 and 30-year risk of cardiovascular disease, and that's shown on the right side of the screen. For individuals with stage 1 hypertension who also have a history of cardiovascular disease, stroke, kidney disease, or diabetes, it's important to start medications promptly if someone has what we consider stage 1 hypertension. For adults with stage 2 hypertension, again, lifestyle is a foundation, but we also need to use medications that have been proven effective and start with at least 2 drugs in a single pill combination. And this strategy likely improves adherence for patients who are diagnosed with hypertension. Now let's transition to what's new. As I mentioned earlier, lifestyle modification is a hallmark and foundation of blood pressure control. So the guidelines emphasize the importance of blood pressure control through lifestyle modification. But a new addition is the inclusion of potassium-based salt substitutes as an addition to the strategy to improve blood pressure control. Now, this could be considered in specific patients who don't have any evidence of chronic kidney disease or are not taking other medications that may affect their potassium levels. Another addition in the 2025 guidelines is the focus on controlling hypertension during pregnancy. Now, in the US, we know that we have a very high maternal mortality rate, and cardiovascular disease is one of the causes of this high mortality rate. And controlling hypertension during pregnancy will ultimately reduce mortality from cardiovascular disease. The guidelines emphasize that for pregnant women who have blood pressure, a systolic blood pressure greater than 160 or diastolic greater than 110, we should manage blood pressure and they should receive antihypertensive medications to lower blood pressure to less than 160 over 80 within 30 to 60 minutes to prevent complications. Now, for individuals who have hypertension prior to pregnancy, or what we call chronic hypertension, it's important that we prescribe medications and they receive antihypertensive therapy to achieve blood pressure control of less than 140 over 90. Now, for individuals who are planning pregnancy or become pregnant and have hypertension, it's important to also consider the use of low-dose aspirin to reduce the risk of preeclampsia during pregnancy. As I mentioned earlier, we have effective strategies in our toolbox to control hypertension, including lifestyle modifications and medications. But what's also new is the use of renal denervation in carefully selected patients. In the 2025 guidelines, there's a Class 2B recommendation to consider renal denervation among patients who have resistant hypertension. So in addition to the 2B recommendation, there are also recommendations for how to manage resistant hypertension. So considering what we define as resistant hypertension, we need to also evaluate patients carefully for secondary causes of hypertension and remove all medications that may interfere with their treatment. And in also considering who would benefit from renal denervation, that evaluation should happen with a multidisciplinary team. So this is a Class 1 recommendation, and this should include experts with expertise in resistant hypertension and renal denervation. Another Class 1 recommendation, which is the highest level of recommendations, is also to use shared decision-making. The decision to use renal denervation among patients who have resistant hypertension or uncontrolled blood pressure on multiple medications should be done by having a conversation with the patient and coming to a shared decision about the benefits and also the risks associated with the procedure. What's also exciting is that we know that there are new treatments on the horizon to treat primary aldosteronism. This is effective in individuals who may have higher levels of aldosterone, and so this treatment will hopefully reduce aldosterone levels and hopefully also help to control blood pressure. Now, in wrapping up our conversation, it's also important to consider that if we want to improve blood pressure control, we need a plan. Blood pressure control doesn't happen by chance. And so the guidelines also emphasize that multidisciplinary team-based care is effective in assessing and addressing patient access to medications, but also other structural barriers that a lot of people may be affected by, and addressing these barriers to achieve blood pressure control. Now, there are also other tools that help to promote blood pressure control. Home blood pressure monitoring is one of those strategies. Home blood pressure monitoring, in addition with clinician support, helps to control blood pressure. And this is accomplished by engaging multidisciplinary team members, including physicians, nurses, community health workers, pharmacists, and also by using a standardized measurement protocol. We need to measure blood pressure accurately to be able to obtain accurate results, and also using treatment protocols. Treatment protocols have been shown to improve blood pressure control, and all of this should be considered in an integrated fashion to improve rates of blood pressure control. Now, the guidelines recommend against the use of cuffless devices that are now very popular because we don't have enough evidence on the validity of these cuffless devices. Now, if you must purchase a blood pressure cuff or a device, make sure that it's appropriately sized and don't rely on cuffless devices because we need more information on the precision and the reliability of these devices. In closing, there's something all of us on this call can do to put hypertension on the map. For clinicians, we need to use validated blood pressure devices and follow proper technique. We also need to act rapidly to control blood pressure and also set very clear goals for our patients. We also need to practice shared decision-making to improve blood pressure control. For policymakers, we need bills and laws that support reimbursement for home blood pressure monitoring and also to improve access to clinicians to improve blood pressure control. We also need to eliminate barriers to access to these effective medications and therapies to improve blood pressure control, and also consider how we can provide treatment programs that will be available to most Americans. We also need to support and community health workers and write bills and laws to reimburse the care that community health workers provide. And for community members and leaders on this call, we need to improve awareness of hypertension and provide community screening events and work in partnership with clinicians and health systems to manage blood pressure. And we also need to promote awareness of lifestyle modification also as a hallmark in preventing and managing blood pressure. And for patients and everyone on this call, that's something we can also do. If you are diagnosed with hypertension, please do monitor your blood pressure at home. Please do purchase a validated device to measure your blood pressure and share the readings with your clinicians, and have a conversation with your clinician to see what the best plan of action would be for you to control your blood pressure. And also share any concerns with your healthcare team, and make the conversation about hypertension control a family conversation. Talk to your loved ones about managing blood pressure and things that all of us can do to reduce the burden of hypertension in the U.S. Thank you.
That was great, Dr. Commodore Mensah. Next up, we will have Dr. Goldberg talk with us about the lipid space.
Okay. I want to thank John Clymer and the National Forum for asking me to speak this afternoon, and I'm going to talk about lipids. So what's the problem? The problem is that high levels of LDL cholesterol, people call it the bad cholesterol, increase the risk of atherosclerotic cardiovascular disease, leading to heart attacks, strokes, and other vascular problems. And you can estimate that about 90 million U.S. adults aged 20 and over have cholesterol levels over 200 milligrams per deciliter, and 25 million have levels over 240 milligrams per deciliter. In addition, a fairly high percentage of children, some 10%, have high cholesterol levels. 1 in 300 people have familial hypercholesterolemia. This is inherited high cholesterol, leading to increased risk of cardiovascular disease because the high cholesterol levels start from birth and accumulate throughout the lifetime in terms of their effect on the vasculature. However, risk can be decreased with lifestyle to start. It's our main foundation of treatment, and this includes a healthy diet with the current and really well-established information being that lower saturated fat intake lowers LDL cholesterol, and one replaces saturated fat with unsaturated fat, poly and monounsaturated fats. Exercise helps. Adequate sleep, controlling blood pressure and diabetes, and particularly avoiding tobacco use, and stress reduction. Most people respond to lifestyle changes, especially diet and treatment of obesity. However, many people need medication and are not started on medication. Our mainstays that have been around now for decades include statins and ezetimibe. Ezetimibe blocks cholesterol absorption, whereas statins decrease cholesterol production. And the combination of these two generic medications, almost all the statins are generic, will get most people to their LDL cholesterol goal. We have new medications. Some have been around for a while, and some are even newer, particularly the PCSK9 medications. So PCSK9 is a protein that affects the uptake of LDL by liver cells and all cells in the body, but particularly in the liver. And we have medications that decrease the production of PCSK9 from the liver, as well as medications, monoclonal antibodies, that block the interaction of PCSK9 with the LDL receptor, the molecule on LDL, on cells that leads to uptake of LDL, removal of LDL from the blood. In addition, we have new triglyceride-lowering medications for people with very high triglycerides in the range of 1,000 and up that put them at risk of pancreatitis. And at least one of these has been approved for people with a severe genetic problem of hypertriglyceridemia. In addition, we have medications for the most severe form of inherited cholesterol, people who have homozygous familial hypercholesterolemia. That is, they have abnormalities in two alleles that lead to LDL cholesterol levels over 400 milligrams per deciliter starting at birth. And these numbers can get up really high with total cholesterol levels up to 1,000. People who are severely affected have very early cardiovascular disease, and we can now use a combination of medications to treat them to prevent their heart attacks and strokes. The other really interesting area right now is lipoprotein(a). So lipoprotein(a) is an LDL-like particle with an attachment called apolipoprotein A. This is only found in great apes and humans and in European hedgehogs for some reason. Elevated levels of lipoprotein(a) cause atherosclerosis, and high levels are associated with increased risks of heart attack and stroke, as well as with an increased risk of aortic stenosis, that is, narrowing and calcification of the main valve leading from the heart. 1 in 5 people have levels above normal, which means that this is a large number of people worldwide. Diet and exercise do not work. The current approach to treatment is to lower the LDL cholesterol and control other risk factors. And we do this with medication, diet, and controlling other risk factors, such as not smoking. There's also a treatment which is apheresis, which is a direct removal of LDL and lipoprotein(a) from the blood, but is not available everywhere, is time-consuming and expensive. However, new treatments are in development, so there are a number of cardiovascular outcomes trials underway with injectables that lower production of apolipoprotein A. So you get a marked decrease in lipoprotein(a) levels. These include pelacarsen, which is an antisense oligonucleotide injected once a month, and several mRNA silencing medications that are also in clinical trials. There's also an oral medication that prevents the formation of lipoprotein(a), so it keeps apolipoprotein(a) from attaching to the LDL-like particle. So this is very exciting, and the first of the cardiovascular outcomes trials will be reporting out next year, 2026, and hopefully that trial being positive will lead to the availability of these medications for people who are at high risk. However, we still have a lot of problems. So we are not measuring lipid levels. We're not measuring LDL. We're following up in many people, including measuring it in children, many adults, and even people after heart attacks and strokes are not either having a measurement done or a follow-up measurement to see how they're doing and whether they're at goal. Many people needing treatment are not treated. So we have lack of access to care, misinformation about diet, misinformation about medications, a very long delay in the uptake of guidelines. In fact, the recommendation for universal screening of lipid levels in children aged 9 to 11 came out in 2011 from the National Heart, Lung, and Blood Institute and the American Academy of Pediatrics. What can be done? Well, we need information campaigns to inform people about lipid levels. They should know their cholesterol. They should know their lipoprotein(a) levels. Lipoprotein(a) only needs to be measured once in a lifetime. We also need the availability of more free testing. There are free tests available from some organizations. It's possible to actually get one's own test done through some of the national labs. Relatively inexpensively. We also need access to care. So we need funding, we need insurance coverage, and this is a major problem right now. The availability of generic medications can get most people to goal, including the statins, which work extremely well and we've had for over 30 years. The current feeling among people doing lipids is that longer and lower is better for LDL. We need to start younger to prevent the buildup of plaque in arteries. We could even prevent the problems from occurring if we could prevent the plaque from developing through lifestyle and medication. This would decrease the numbers of strokes and heart attacks, which would lead to enormous cost savings financially, societally, and for the individual to decrease pain and suffering. Thank you.
Thank you, Dr. Goldberg. Next, we'll have Dr. Shaw talk to us about the role of technology.
All right. Wonderful. Thank you guys so much. Great to be here. I am going to shift gears here a little, and I'm going to make some speculations about the future. I think there's a lot of exciting technology on the horizon, and really the question is, how are we best going to harness that to address some of the challenges? So if I pick up on a couple of the other speakers' comments, Yvonne said that 120 million people in the US have high blood pressure. And Anne said 90 million people have high cholesterol, and many people are not checking their cholesterol, and the guideline uptake has been slow. So these are challenges we need to address, and I think it's possible that technology can help us address some of these challenges. So what I want to do is talk about kind of different threads of technology that can now be strung together to help scale what we do. So if you take a look at this image, these are some of the puzzle pieces or variables in the equation, going from left to right. So first, we have digital health platforms. So you can think of that as the wearables. You see probably everybody has a different many people have different types of watches. And I'll mention a few companies, but I don't have any stake or relationship to those companies. So for example, the Apple Watch has the sleep apnea detection, now a hypertension notification. The Oura Ring has many different biometrics. The Whoop Band has stress recovery, apnea, and now they actually have a blood pressure notification, which the FDA is challenging. But all of these wearables are collecting biometric data about their users. But the other thing they're doing is building platforms. So platforms are a place where data gets aggregated in reusable ways and allows sharing, essentially. So if you build a platform, a health data platform, people and apps and enterprises can build additional features on top of that platform. So like one important way this field is evolving is that these platforms are now collecting different types of data. So for example, Whoop has their biometric data, but now they have something called advanced labs. So users can pay a subscription fee and they partner with Quest Diagnostics and they can go get their blood test. In the app, they can request a blood test and they can go to a Quest lab and get that checked. So you can go get your cholesterol checked through the app. Oura Ring has something similar. It's called Health Panels. And these are essentially creating platforms that we can then build off of. So the next piece of this equation is the LLMs, evidence-based LLMs, large language models. I think people might be familiar with this because of the popularity of ChatGPT, which is a large language model. Users can input a prompt or a question, and the model will return human-like text to answer that question. Now, there are specific medical and health-related LLMs. One example here is Open Evidence, where you can enter a question and it will give you an evidence-based response. So for example, if you look at the Whoop website, they show an image of a woman who's checked her labs with their advanced labs and she has a high CRP. So I took this and I said, okay, if I gave this to Open Evidence, what would it do? So I put a 45-year-old, otherwise healthy woman has a high CRP. What should she do? The LLM said, they gave me sort of four pieces of the response. One is high CRP is associated with cardiovascular risk. Lifestyle is the cornerstone of intervention. Your doctor might choose to do a 10-year risk based on the ACC-AHA equation. And they might consider additional coronary CT score to risk stratify for statins or other interventions. This was correct. They provided references. This computer model gave the correct answer. So hopefully you can imagine how these pieces of technology will string together to allow users to collect their health information and then understand and do something about that information. The final piece of this equation is generative AI. So Gen AI is a huge field. The example I'm going to use here is how can we use this technology to deliver information to an end user or a patient? So for this little experiment I did here, I took the response from Open Evidence's LLM, about the CRP. I put it in Gemini, which is Google's model, and said, can you make this in some simpler language that a layperson can understand. And then I took that as a prompt and put it in Sora. So Sora is ChatGPT's most recent video generation model. I said, using the likeness of me, deliver this message. And this is what it did. So a computer generated this. I did not videotape myself saying this.
High CRP levels indicate inflammation and may signal future heart problems. If your risk is high, a doctor might recommend a coronary artery calcium scan for more information. Statins may also be recommended.
So hopefully this allows you to see how technology can be joined together to deliver an experience and important information to an end user. And there's one more piece of the puzzle that I think is worth mentioning, and that's the money. Who's going to pay for all this? So I think in 2025, an interesting thing happened. In the One Big Beautiful Bill Act, it passed in July, that legislation said that HSA, health savings account dollars, could be spent on direct primary care. So direct primary care can be subscription type services. And these digital health platforms are moving into that space. So for example, the Oura Ring has a partnership with a company called SteadyMD to have clinicians oversee parts of that care delivery. So the HSA dollars going into this type of healthcare delivery is not negligible. In 2024, the estimate that $42 billion was dispersed from HSA accounts. So it's a substantial amount of money that could potentially be used to fuel this innovation. So if you look at this equation end to end, hopefully what you see is an opportunity to scale. 190 million people with high blood pressure, 90 million people with high cholesterol. How are we going to reach those people? So if you notice here in this equation, there is no clinician, there is no cardiologist like me. There's just the likeness of me. And that, if we can do it well, that's what's going to allow us to scale. A physician or especially a cardiologist cannot see all of these patients. So I think it's sort of exciting. Of course, there's a ton of questions that need to be answered about how to do this. But in my speculation for the future, it's here. It's going to happen. So I want to leave you with one last thought. So I have I have a son who loves baseball. This summer, we watched a movie called Moneyball. And I think there's an analogy here. So this is Jonah Hill. He's playing Peter Brand, who was in charge of turning around the Oakland Athletics team. And he did that with computers and statistics. He turned the Oakland A's into a winning team. And at the end of that movie, the manager of that Oakland A's team went to Boston and was trying to get recruited to the Red Sox. And the owner said, anybody who's not rebuilding using your model, they're dinosaurs. They're going to be sitting on their ass in October watching the Boston Red Sox win the World Series. And that is precisely what happened. In 2004, the Boston Red Sox won the World Series. So I think the rules of the game are changing. And that makes an exciting time to finally scale and reach all these people who need new ways to manage their health and more effective ways to manage their health. So I think the needle is going to move here. And that's an exciting time to be in the field. And with that, thank you.
So can I just make a comment? Rashmi, I was interested in the app for people getting cholesterol levels done. I do know that I have some patients who are able to go through a national lab such as Quest and actually get a cholesterol level done. And it tends to be, they can do it without the need to go see their primary or their other doctor. Do you know what the uptake is of that at the moment?
So I know the Whoop device, they're not live yet. It's called Advanced Labs. And I think there's a long waiting list for people to get on this service. I'm not sure if they've gone live with that. I think it's really early in that space. I personally love it. Now that I'm a little bit more on the patient side as I get older, it kills me that I need to order to go get my cholesterol and A1C checked. That makes no sense. So I'm all for pushing more out to the patient or end user to manage it themselves, because they don't need me to order them to get their lipids checked. It makes no sense. So I'm very excited to see where that goes.
I'd love to talk to Anne and Yvonne about the role of lifestyle and food interventions. A lot of the work I'm doing at the American Heart Association is in the food as medicine space and really working to kind of further the evidence base there to make those interventions more accessible. So maybe Anne and also Yvonne, talk to me about what your thoughts are on those types of interventions and the combination with some of the other things we talked about.
Well, we have data going a long way back about saturated fat and LDL, and really a lot of this involves making small changes in some foods that the AHA has recommended a long time. We're not talking about necessarily decreasing total fat in the diet, it's just the proportions. And thus, if you change the cuts of beef, if you eat more chicken and fish, if you avoid tropical oils that such as coconut oil that will raise LDL quite reliably. In addition, more vegetables in the diet, more fruit can help both with lipids and with blood pressure. Less processed food, in that we want to avoid sugar sweetened beverages. We want to avoid a lot of simple carbohydrates that can push up blood sugar and triglyceride levels and contribute to weight gain. I think that the data are quite robust. It's just a matter of making sure that people have the right information. There's a huge amount of misinformation about food on social media. And when one goes to Instagram and sees various, quote, influencers talking about this, who are not dietitians, who are not physicians, who push out things such as seed oils are bad. There are no data that seed oils are bad. In fact, high polyunsaturated oils can actually lower LDL and triglycerides. So there's a lot of work to be done. The other issue is how much exercise, when to exercise. There's a lot. Again, we have fairly nice data showing a benefit of all of these things. It's just a matter of getting the correct information available and for people to believe the correct information.
Yeah. Well said. Well said. Yvonne?
Yes. So just building on that, in terms of prevention of hypertension and management of hypertension, we have what we call the DASH eating plan, not a diet. And I actually like that we refer to it as an eating plan because it doesn't require any special foods or strict adherence to a diet per se, because we know that most diets don't work, right? So if we can identify an eating plan where, as Anne mentioned, that we're eating more fruits and vegetables and whole grains and choosing low dairy products. And one thing I also want to touch on is sodium, right? We know that when it comes to hypertension, lowering sodium intake is one of the proven strategies to prevent and control hypertension. Now, the goal is less than 2,300 milligrams and ideally less than 1,500 milligrams, but the average American consumes more than double that on a daily basis. So for me, apart from talking about what we put on our plate, how can we also partner with the food industry to make our foods healthier? And I say that because in the context of processed foods and even the foods that our children eat and foods that they are fed in schools, right? There are a lot of factors that sometimes are beyond an individual's control. So how can we work to lower the sodium content in foods that are already processed and produced in mass quantities? Now, this is a national forum. And as we think about strategies, I also like to think beyond sort of individual level strategies. What can we do as a society to improve access to healthy foods, but also make the healthy foods affordable, right? We talk about fruits and vegetables, but there are a lot of communities where there aren't grocery stores where one can purchase fruits and vegetables and adhere to the 5 servings of fruits and vegetables a day. For a lot of people, this is beyond reach. So as we have these conversations, I love that we're also thinking about how we can work on policies that will make some of these healthier foods more accessible to all Americans.
Yeah, I'll pick up on one point there. You know, when I've given similar talks in the past, I often used to end my talk with the idea that apps will not make people healthy. It's the food supply, it's the built environment. And I did not include it in this one. And the reason I didn't is because the way those things are going to change, I wonder how much of that change is not going to come from policy, it's going to come from market pressure. Like there needs to be market pressure to change those things. Otherwise, they won't change because this is a, capitalistic society and you need to create and how do you create that sort of pressure? I'd love to get people's thoughts about, I think I see two sort of possibilities where there could be some market pressure. One is alludes to the things I spoke about, which is creating a scaled way to deliver reliable information so people know what they should expect in their foods or what they should expect with their health. That will create some market pressure. And the other is the GLP-1s. A huge number of people on those GLP-1s are going to change what they eat. So I think there are two ways we can sort of exert market pressure for these changes, because I'm not totally hopeful it's going to come entirely from policy.
Well, I think with policy, you have to have people agree. And I think we have, in many cases, a lot of disagreement in spite of the data. And I think part of the problem is that people do not believe in data anymore in many cases. And so it's up to all of us, I think, to really promote that and to have conversations with patients and empower patients and our community members as well. Community members saying, listen, this is what we need. Why don't we have it? And work on policy.
Yeah. Yvonne, you've done so much work at the community level and working with stakeholders across those kinds of groups. What would you maybe add about community-based programs and interventions you've been involved in and where you might see some promise here as well?
Thank you, Juliana. Really, that's where my practice is. I don't see patients at the bedside. My practice is in the community. And for me, I think there are so many opportunities to take all of this amazing expertise in a lot of our health systems. And people use the expression, meet people where they are, but it's the right thing to do because that 15-minute encounter is not enough for most people to really understand what it means to prevent hypertension, what it means to control cholesterol. So really partnering with community-based organizations and being more visible in faith-based communities. I'll give one example. We did a screening at a church in Baltimore, and there was a gentleman who was a firefighter who just retired. And he told me his blood pressure has always been great. He runs about, 5 miles a week and is very active. And since he retired, his blood pressure has just started increasing. And so we started talking. He said, well, you know what? He's started binge watching this show, and every night he has a cup of chicken noodle soup, right? So that was his comfort food. Because he retired and had started watching this show, every night he would start, he'll get a cup of chicken noodle soup. And then we talked about the sodium content, and he was shocked. He said, I didn't know, chicken noodle soup was so high in sodium. So that's an example of education, right? Teaching people to read food labels. Like when you purchase a can of soup and you look at the ingredients, if it starts with sodium and there are 800, 900 milligrams of sodium in that can, know that you already have used up majority of your quota for the day. So I think communities are where we have an opportunity to do a lot of education, promoting awareness about home blood pressure monitoring, promoting awareness about prevention, right? I think if we think about the 120 million Americans who have hypertension, there's another 120 million who don't. So what are we doing to prevent that progression to hypertension? I feel like we don't spend enough time talking about prevention. People who may be in the stage 1 hypertension or elevated blood pressure range, where we just wait and see. And then those individuals over time progress to stage 2 hypertension. We need to invest more in preventing hypertension and partnering with communities to reverse that trend towards stage 2 hypertension.
Maybe another thing to pick back up on is this issue of getting trustworthy information out to the public, and this, and kind of combating the misinformation in that space. Rashmi, you gave such a powerful example of kind of quickly leveraging technology to put together a very simple patient-focused video. Do you have other thoughts on how we can leverage these new technologies for good in terms of combating the misinformation and getting out the credible science in consumer-friendly ways?
Yeah. I mean, one thing I mentioned but didn't go into is the the physician was not in that equation. And ultimately, somebody is going to control the narrative. And we better put ourselves in that seat. If we really, really care about solving this problem, it's unlikely to happen at scale unless we are deeply involved in the technology. And I think what that means, even in the last month or two, my opinion of how that could happen has changed. So before, you have to be part of the team, build the solution, not just be a consumer of the solution. You have to be part of building the solution. And the assumption there is that a problem needs to be solved, which I think we can all agree on. The way we're doing it today is not working. Now I actually think, because of all the AI tools, I think clinician builders need to start building. It is much, much easier today to build an app. Anybody can do it with human language. All the tools that AI, you just write a prompt and it'll give you a whole set of code. You just have to get a little out of your comfort zone. So instead of trying to partner with the people doing it, which is really important, there is going to be an emerging opportunity to just build the solution yourself. And I would love to see that, because if you can properly use all the AI tools to build software solutions or other types of solutions, the dependencies on other places really, really goes down. And that's going to help us scale and kind of more effectively control the narrative, if that's what we want to do.
Dr. Goldberg, did you want to add to that?
Well, I think that part of it, and one of the reasons that the National Forum is so great, is that what we really need to do is all get together and work on both information dissemination, community engagement, and in fact, we really need to all be involved in public policy. I think that, clinicians all need to work together. I mean, a team's approach is good when in the individual practices, but in fact, I think we actually need to work across multiple areas, multiple venues, multiple public health programs. And we also need to elevate public health again to where it needs to be. It has taken a lot of hits over the last few years, and I think it is up to us to get it back.
Well said. Well said. I'll go in maybe in a slightly different direction, focused on the clinician. This is a really exciting, for me, it's a really exciting several months or about a year with the new hypertension guideline coming out just a couple months ago. We have new guidelines coming out in lipids and cardio-kidney metabolic health, and then primary prevention. I feel like this is this year of new guidelines. Thoughts on what we can and should be doing to ensure clinicians are getting the latest guidelines and really able to kind of rapidly integrate them into their practice. We know that it's going to be a lot of new information coming at them, in sequential order. So any thoughts from this group on what we can do better to equip clinicians with this new stream of guidelines?
I think that some of what Rashmi has talked about is the whole use of technology to make the guidelines more accessible. So you put the guidelines in the electronic medical record, you provide apps to clinicians that they can use on their smartphones, which they carry around with them all the time, and say, okay, here's the prevent equation, here's your risk, this is how we do it, and other apps that make life, that integrate the guidelines into the technology, because you have to have it right in front of people as they're talking to patients or even giving talks or talking to communities.
Yes, and I'll just add that you're touching on an important point, which is implementation, right? So writing the guidelines is the first step, but what is it going to take to implement these guidelines? I'll use the 2025 hypertension guidelines as an example. So there is a recommendation, class 1 recommendation, the highest level, that for adults with uncontrolled hypertension, team-based care is recommended to achieve blood pressure control. We know that there's so much hypertension to go around, with 120 million people affected by hypertension. So if we want to implement team-based care, what are some of the things that will support with implementation of team-based care? Health systems are not going to engage community health workers and nurses in managing blood pressure if that care will not be reimbursed. So as we think about the strategy and implementation of team-based care, for me, I'm very interested in how we can take the evidence that exists and accept the evidence and do the work to allow more healthcare professionals to join this effort to control blood pressure. I think a lot of the turf wars are harmful to patients, especially those in rural areas where there may not be a primary care physician. There may not be an amazing cardiologist like Dr. Shah, right? So what does it look like to still improve access? How do we leverage technology, and how can different healthcare professionals partner? It's all about partnership. I think when we center all of our efforts on patients, that's when we win. So it's a great point, and I think that we all need to find ways to advocate for policies that will allow us to implement team-based care.
Okay, well, this has been a really fascinating and exciting discussion. I think we've all taken away a lot of really important points about how we can better manage these risk factors in the community, how we can support clinicians and patients, and a lot about what's on the horizon in terms of innovation that's going to make it easier for patients and clinicians to get these risk factors under control. Thank you all for your time.
Juliana, thank you for leading the panel and for allowing me to join you now to co-lead the Q&A session. It's going to allow us to take advantage of your role as an expert and not just a facilitator. I loved in that panel how there at the end with Yvonne's comment about what's needed, the incentives, the reimbursements to support team-based care. It ties in so well with the discussion with the last panel and throughout the day, something that we desperately need. Dr. Knight, glad you were able to rejoin us from clinic. Thank you very much. And great panel, great discussion. So we have lots of questions. Some of them are sort of micro questions about what a patient might ask or wonder about. But I want to begin with the confluence of conditions that are in front of us right now. New technology, new guidelines, new treatments to manage risk factors. Juliana just talked about her excitement from all these new guidelines now. When you take these things together, is this a moment for cardiovascular and metabolic disease prevention?
From my perspective, it absolutely is. And I think one of the things that I get really excited about is as these guidelines are coming out in this way, it's the interconnectivity of these conditions and the way we can simplify for the patient who might be feeling as though in the past their conditions might have been managed in silos. And so to me, one of the messages we're really working on is how can we help simplify to the patient how all of these conditions are interconnected and how we can treat the whole person in this way. So that's one of the things that I get really excited about, and how these guidelines are coming together and how the system is starting to move around the patient in an even more centered way than maybe we've seen in the past.
Okay, so Juliana says, yes, this is a moment for cardiovascular and metabolic disease prevention. Anybody disagree?
I would agree
Okay.
with that. I think that not just guidelines, but actually what some of the therapeutics that we have now really can target multiple conditions, including things like obesity. And when you start dealing with that, you start dealing with the hyperlipidemia, you start dealing with the hypertension and the diabetes and everything else. So I basically tell a lot of my patients, this is all one problem, but we need to approach it in different ways.
Yes. So with the agreement that this is a moment, and moments are time limited, right? How can we capitalize on it before people's attention turns to the next thing? Dr. Knight, what say you? You're on mute.
We don't want it to be the flavor of the week or of the month, right? And so how do we incorporate this into comprehensive patient care? When we talk about prevention, it's not just primary prevention, secondary, it's tertiary. So whether I'm seeing a patient who is worried about heart disease because it runs in their family, or someone who had a heart attack 3 months ago, there are new therapies that add to our existing armamentarium. And that's what's really exciting about this. A lot of what we're seeing is not to replace what we have. It's actually adding synergistically to continue to reduce that risk. And so when we think of residual risk, right? So I'm doing everything, I'm following all the guidelines, but my patient still has a risk of future cardiovascular disease. What we are seeing now, whether it is obesity treatments, whether it is dealing with diabetes or directly on lipid or other cardiovascular issues, what we're seeing is further reduction. And I think that's very exciting. And it's something that no one should be able to ignore in the healthcare space.
Very well said. Thank you. Yvonne, anything that you would add to that?
Just building on what Dr. Knight just said, I share his excitement and enthusiasm also about new therapies. And in the hypertension space, as he suggested, there's also another tool in our toolbox to help control blood pressure, which is renal denervation. So for a lot of patients who may not tolerate medications or are taking 6 or more medications, what does it look like to offer another option in addition to lifestyle, in addition to medications, to help lower their blood pressure and reduce their risk for cardiovascular disease? So I share this excitement for newer therapies, but also not forgetting the basics, not forgetting the importance of promoting lifestyle adherence and ensuring access to medications to control blood pressure. But as he said, we need to ensure that care is integrated. If someone has hypertension, high cholesterol, diabetes, they shouldn't be running around trying to figure out who to go to at what time. Our care models need to be more integrated for a lot of Americans who have multiple chronic conditions as well.
Very well said. Thank you, Dr. Commodore Mensah. Dr. Goldberg called attention to screening and treatment gaps as problems. And I know, Dr. Commodore Mensah, you've written extensively and spoken extensively about those problems with blood pressure management too. So what actions can we take next week to solve them?
So I think you're directing that question to me as well. In terms of action, we need to implement the evidence-based strategies that we know work. In the space of hypertension, home blood pressure monitoring is one of them. Team-based care is one of them. We talk about technology and tools that are available. We also need more people. It's not enough to give someone a home blood pressure monitoring device, but they need additional support in the form of a person who's going to teach them how to measure their blood pressure accurately, how to share their results with their clinicians. So We need to implement the guidelines. We need to really take all of the evidence that exists and improve access to primary care clinicians and the overall healthcare team as well.
Yeah, you mentioned team-based care as an evidence-based intervention or implementation tool. Sarah Eve Sarliker mentioned in chat standing orders for blood glucose and lipid levels. What are your thoughts about that? What about standing orders as a tool to solve this problem with insufficient screening and treatment?
I can take a stab at that one. So the bigger implication there from my read of that comment is that how do we get rid of the roadblocks or constraints that prevent people from accessing the simple things they need? Many people, everybody is, the solution is not simple, but for the many people for whom the interventions are not that complicated, how do we get rid of the roadblocks for them to access those things? One example is just, why do I need a prescription to check my hemoglobin A1C? That makes no sense. That's like kind of where I feel like there's a lot of excitement in my area of the world, the bubble I sort of live in, that we can get rid of roadblocks, right? Like, I am too expensive to manage blood pressure. It makes no sense. I'm not scalable, if I think of it that way. We have to make it much easier for people to access things. And the way we do it today with brick and mortar, one-on-one, and if you need 3 people in the medical establishment to manage your blood pressure, that's a relatively uncomplicated case. That's a failure because it's not scalable. We're never going to reach the population if those are our solutions. But I think we're at an inflection point where it's really possible to get rid of some of these constraints and roadblocks and alter the system a bit in a way that'll help us achieve the goals we need to achieve.
Thank you. I know all of you have done extensive work on disparities in care and access to care. Pam Morris from University of South Carolina, or Medical University of South Carolina, asks, could you comment on the digital divide and access equity issues? We have about 5 minutes left, so I'll ask you to try to be brief.
I'll just say 2 things. Assumption, what we're doing today is not working. And finally, tech and digital will help us do something differently to solve this problem. We're not going to worsen the problem. The problem is really bad today. The digital and tech stuff is going to help us solve the problem, is my position, if we do it well.
I think, though, that the problem is access. I agree with Pam, and that internet access is not available everywhere in the country. There are rural areas that don't have it. That infrastructure could be dealt with. We could do that. And then other ways of teaching people. So I have elderly patients who cannot manage my chart and who have trouble with their phones. And so it's going to require a lot of education. And I think it's going to require a lot of money, which, depending on whether that's forthcoming.
Michael, I'm going to ask you, and sorry, I didn't give you a heads up on this, but I'm going to ask you to wear your National Medical Association leader hat and answer this one.
Yeah, I think it's, thinking about the burden of disease, the communities that have, are being affected disproportionately, whatever community that is, whether it's whether it's geographic, whether it is cultural, how do we meet those individuals where they are? How do we give people the tools that they need to be successful? And I think that is what we can all agree upon. If it's someone that needs technology and a technology connection, let's do it. Let's take down the barriers of having to be somewhere physically if I can connect with you on an app. But if you don't have the technology, how can I still meet your needs? If you're in a rural community, how can I meet your needs? If you don't speak English, how can I meet your needs? If you have cultural discordance and the things I'm saying are not landing with you because these are foods that you've never heard of, or these are activities that you've never done, you've never seen your parents do, how do we meet people where they are? And I think that brings us together as a part of the healthcare community to use our own backgrounds, but also to learn from each other with cultural humility so we can meet people where they are.
Yeah, I see Dr. Commodore Mensah nodding. Juliana, you sit right at the intersecting point at AHA for communication and patient education and standards for clinical practice and public policy. It all comes together there. How are you? What are you most concerned about, and what are you most excited about with respect to Pam's question about access equity?
Well, yeah, I agree with all of our panelists here that there's lots of problems to solve, and we have to be working on many different levels to do that. And so, from Anne's point, we have to work on the policy levers that are going to expand access. I think technology is moving us forward in new ways to start to decrease the divide, as maybe where it wasn't doing that many years ago. And the other strategy that AHA often deploys is our relationships at the community. So in community-based organizations and community-based supports that can fill in the gaps as well. So it's not any one strategy. We kind of have to move all the levers of our organization to work on these equity issues as technology catches up and divides, narrow. So it's a lot to be done, but I think it can be done with a comprehensive strategy.
Which takes us back to Dr. Oz's watchword in his keynote of hope, because there are things we can do. Yvonne and Anne, John Lochner asks, with medication adherence such a challenge, are there drugs on the horizon in both hypertension and cholesterol that are needed less frequently?
Well, we have definitely some drugs for LDL at this point that's available. Inclisiran can be done sub-Q every 6 months for lowering LDL. I think we're not quite at the point where everybody's going to be on such a medication. It's expensive when many of the other things are generic and cheap. As far as there's also some other medications with regard to severe hypertriglyceridemia that are also going to be once a month or once every 3 months or thereabouts. And LPLA drugs are coming, that is once every 6 month or once every 3 month injectables for that. So there are things that are going to be helpful for decreasing risk overall, but I don't think we're going to totally get away at this point from the readily available generic, inexpensive day-to-day medications for hyperlipidemia.
Great.
Right. And
Dr. Commodore Mensah.
And just building on that in the context of hypertension, I'm not aware of any long-acting antihypertensive therapies in terms of medications in the pipeline, but what we do have is renal denervation now, and in the guidelines, the 2B recommendation that in some patients who have resistant hypertension or are unable to tolerate medications, this may be an option. And I do think that this also addresses the issue of medication adherence, because we know that almost in 50% of people who are diagnosed with hypertension, they are non-adherent to their therapy. And for most people who are prescribed blood pressure lowering medications, they work. But in some people, they just cannot take them because of different reasons, or their lifestyle. They may always be on the road and just struggle a lot. And in those patients, we still need to offer options to lower their blood pressure and reduce their risk. But right now, the recommendation is that it's an adjunct to lifestyle and medications, but it's another option to help address the issue of medication adherence and hypertension management.
All right, thanks. We've been perfectly on time all day. There's one more question that it's a huge question. It goes right to Dr. Shaw's wheelhouse, but I think it's important. All of you will have important perspectives. So, Juliana, if you're willing, with your permission, I'd like to give each of you 30 seconds to answer a big macro question. Dr. Shaw, you said that tech must counter misinformation, and that jumped out at me as such a timely comment with the profusion of myths and disinformation about health and medicine today. So how can we use tech to counter it?
Yeah, it's not tech that has to counter misinformation. It's people who want to send different information need to counter misinformation. And that gets to the idea of, the one example I gave is clinician builders. If you want to control the narrative, you got to get into that space and start doing those things. I'm sure there's a whole regulatory side to this type of conversation that there's some conversation around that, which is not exactly my expertise, but it's, you have to get in the game, right? It's the people. It's like the people who tech doesn't control it. It's the people who control the narrative.
Very good. All right. Dr. Knight, 30 seconds. How do we counter mis and disinformation?
Relationship. I think relationship building. When I meet a patient for the first time, they may believe what they see online more than anything that I can say. I have all my diplomas on the wall. That means nothing because they don't know me. We don't have a relationship. But once we have built that relationship, I will tell you, patients, particularly if we think about the COVID time, patients would come to me and said, I've heard all of these things, but I want to know what you have to say because we have a relationship. So how do we, again, meet people where they are? That's a human touch that we are not going to be able to lose or replace. Let's build that relationship and let's guide our patients, let's guide our family and friends to trusted resources so that they can achieve their best health potential.
Thank you. Great insights. Dr. Goldberg.
Well, I don't know that I could actually improve on what Dr. Knight said because it was perfect. But I think that what we need to do is we need to get people the right information, and that can either be in the one-to-one. I think we could also do it through getting some of our patients to talk to other people. So communities of patients can be really helpful. If you know somebody else who has, say, familial hypercholesterolemia, that can be extremely helpful. So the patient communities and wherever those communities are and whichever communities we can work with where they trust us.
Trust, relationships. Yeah. Dr. Commodore Mensah.
My word was actually relatability because in addition to being a credible source, I was thinking about people being able to relate to you as the messenger. And so we really need to make sure that we're getting healthcare professionals and communities and breaking down information in a way that is trusted, but also relatable. Because if I show up in a beauty salon and I'm talking about blood pressure measurement, it has to be at a level that people can relate to and understand as well.
Excellent. Thank you. Juliana, bring us home.
Last comment. Okay, awesome. Maybe I'll take this a little bit tactically for what we are doing as an organization at the American Heart Association, that we are really drastically rethinking the way we deliver content and the way we create content in order to leverage the technology that's out there. So we're bringing in new expertise to the organization to rethink how we deliver content within properties that we own, but also really moving much more to a channel strategy. And I think this was said best, we have to meet people where they are through different kinds of channels. And so really just rethinking our entire strategy as an organization that does have the trust of the public to deliver content in new and different ways. And so we can leverage the technology, but leverage the science folks, the leaders and volunteers of the organization to push that content out there in new ways. So it's a topic we are talking about within the walls of the AHA every day, because we know we have a great moment, but we have to rethink how we do it to make it happen.
Thank you. Well, it's a huge challenge that it'll take all of us to meet it, and concerted effort by all of us. Well, gosh, Ann Goldberg, Yvonne Commodore Mensah, Rashmi Shah, Michael Knight, Juliana Crawford, y'all have shared really valuable insights. I'm pretty sure I gained a couple of IQ points by listening to y'all. So thank you from a personal level. And thank you so much for being here and participating in the 2025 National Forum annual meeting. Thank you to all of our speakers today so far for your thoughtful presentations and engaging so meaningfully in the discussions. Now, as we turn to our final session, taking action, participants respond. We invite you to stay with us as we continue building momentum toward action. A number of meeting participants will showcase their impactful work and tell how they are championing heart disease and stroke prevention. If you would like to participate, please notify us via the Q&A feature, and time permitting, we will get you into the lineup. To begin, I'm going to let him introduce himself, but I'll just say a valued, cherished friend personally, and a great collaborator to the National Forum to tell us about at-home screening for LDL-C and Lp(a).
Well, great. Thanks so much, John. And I'll use maybe 10 seconds of my 2 minutes just to congratulate you and the National Forum team on really another superb annual meeting. Always a great conversation and high impact. So really appreciate all the effort that goes into organizing this and appreciate the opportunity to highlight some of the work being done by the Family Heart Foundation. My name is Hilly Page. I'm the Chief Innovation Officer for the Family Heart Foundation. And we are an organization, a nonprofit patient advocacy organization that supports people with the two most common inherited cholesterol disorders. That's FH and high lipoprotein(a). Lipoprotein(a), as I'm sure you've heard today, is prevalent in 20% of the population, but unfortunately only 1% of individuals are diagnosed because it's not part of a standard lipid panel. And unfortunately, regarding LDL cholesterol, the situation in some ways is even more disappointing in that 41 years after the publication of the first trial showing that lowering LDL cholesterol reduces risk, we are still doing a suboptimal job with awareness, treatment, and control of LDL cholesterol. So with all that in mind, the Family Heart Foundation launched a program called Cholesterol Connect just about a year ago. This offers free at-home testing, finger stick testing for both LDL cholesterol and lipoprotein(a). So anybody in America, regardless of their insurance coverage, can go to cholesterolconnect.org is the website, order a test kit, comes to your house. It's a simple finger stick. And in about a week after you return the test kit, we'll send you a full lipid panel along with your lipoprotein(a). And what's a little different with this program, because sometimes traditional screening programs, there's a lack of follow-up. For this, our Care Navigation Center will reach out to anybody with either a high LDL or a high Lp(a) to offer support, educational resources, and connect them with their physician. And so we've sent out over 18,000 test kits so far since launch, and we would invite you to please go ahead and order a test kit at cholesterolconnect.org. Thanks, John.
Thank you, Hilly. Congratulations. A really terrific initiative. And we're proud to be collaborating with the Family Heart Foundation on it. Next, we're going to hear about combating hypertension awareness across Wyoming.
Hi, my name is Kara Beach, and I'm the regional coordinator at the University of Wyoming Center on Aging. The Center on Aging took a unique approach to leverage Wyoming's extensive public library system and distribute self-monitored blood pressure kits throughout the state. This collaborative effort with the Wyoming Department of Health Chronic Disease Prevention Program and the libraries deployed almost 300 kits in all 23 counties and at 67 libraries across the state. The strategy transforms a library into an accessible, non-clinical hub for preventive health, directly addressing the critical need of vast rural states and removing common financial and geographic barriers to blood pressure monitoring. A key success to this program has been engaging individuals who previously neglected monitoring their blood pressure. Since December of 2022, this program has achieved a remarkable 1,521 checkouts statewide. Notably, prior to participation, less than half of the participants had ever monitored their blood pressure before. And this highlights the program's innovation in reaching and activating those in need for early detection and management, making significant gains in understanding the confidence among new blood pressure monitors. We work to overcome the challenge of underdiagnosed hypertension and health disparities. In our rural state, there are only 500,000 people, and we are the 10th largest across the nation. But heart disease is the #1 cause of death in Wyoming, and hypertension it leads that, and it's often symptomless, of course, and our risk factors are heart disease and stroke. By placing these kits in accessible community cornerstones, which are our libraries, we're tackling this challenge by ensuring that all the residents, regardless of their socioeconomic status, have access. And I'm out of time, but thank you so much.
Well, congratulations, Kara. A very exciting and innovative program.
Thank you.
Our next speaker will tell us about freestanding blood pressure kiosks that are almost completely across the state of Arkansas.
Thank you, John. I don't know if people can see me, but we'll worry about that later.
Yeah, please go ahead,
Okay.
Dr. Simon.
Yeah, thank you, John, for this opportunity. My name is Bala Simon, a proud Razorback. Though we are down 2-5 this season in football, my organization is the Arkansas Department of Health, a centralized health department which serves over 235,000 Arkansans every year. We took a unique approach to strive towards equity in the state. Arkansas is a small rural state of about 3 million people, and it consistently ranks high among states with the highest heart disease-related deaths. Undiagnosed and uncontrolled blood pressure are leading risk factors for heart disease and stroke deaths in the state. Arkansas is also a poor state where many of our residents cannot afford a blood pressure cuff. Many of our residents cannot afford $30 to $50 to purchase a blood pressure cuff, which is not covered by most insurance plans. Also, most Arkansas residents do not have access to freestanding blood pressure kiosks, such as those seen in Walmart, Walgreens, or CVS in urban states. As a matter of fact, Dollar General and 7-Eleven are more common in rural Arkansas, and they don't have kiosks. So our health department was able to secure CDC public health infrastructure grant to expand access to freestanding blood pressure kiosks in all our local health units. John said almost all. I said 90 of 94 because the last 4 are WIC-only clinics and they are open only part-time. So we have blood pressure kiosks in all 75 counties in all of our local health units, availing Monday through Friday, 8 to 4:30. These kiosks offer an easy, accessible way for residents to measure, monitor, and take steps towards better blood pressure control, and helps with our equity concern. So thank you for this opportunity, John. Back to you.
Thank you, Bala, and congratulations. Next, we're going to hear about multiple food is medicine interventions from another cherished friend of the National Forum.
Thanks, John. Hi, everyone. My name's Dr. Marty Mackey, and I'm the president and CEO of Project Angel Heart in Denver, Colorado. We are a statewide nonprofit community-based organization that advances food as medicine principles, primarily nutrition security. We deliver medically tailored meals to those living with severe illness, all up and down the Rocky Mountain range to support health and well-being. We provide about 815,000 meals per year to over 5,000 clients up and down the Rocky Mountain range and across the state. About 40% of our clients face serious cardiovascular disease, primarily COPD, heart failure, and certainly hypertension. And we're actively involved in policy change that supports food as medicine services, as well as screening, testing, referring. Nutrition is part of a treatment plan. But as we do a lot in the food as medicine area, I wanted to share just one project that we're involved in that is impacting our state. We are partnering with 3 organizations: Colorado Access, which is one of our managed care, Medicaid managed care organizations; Denver Health, which is a health system that serves mostly Medicare patients in Denver; and the Food Bank of the Rockies. And what we're trying to do is really pair up nutrition security with food security for patients who are discharged after having had an inpatient admission for congestive heart failure or comorbid cardiovascular diseases and type 2 diabetes. And those particular participants in this project received 12 weeks of medically tailored meals. The highest intervention at Food is Medicine. And then they stepped down to medically tailored food boxes from the Food Bank of the Rockies for 6 more months. And what we're really looking at is decreases in inpatient readmissions, emergency department admissions, nursing home admissions, as well as discharge planning systems change. So as a nutrition security organization, we are really excited about the collaboration with a food bank to make sure that people get what they need through Food is Medicine interventions. And we're super excited about the results that we're seeing already in terms of decreased admissions and connecting people to health-related social needs through our approach. I'll stop there.
Well, congratulations, Dr. Mackey.
Thank you,
Exciting
John.
work.
Thanks.
So let's move on to an LDL quality measure update.
Hi, John. Thank you. And thank you to the National Forum for the opportunity. This is Brian Hart. I'm the Executive Director of the National Lipid Association and the Foundation of the National Lipid Association. The NLA is grateful for all of the presentations today because they outline the different levers that are going to help us improve guideline-directed care. And the one that we've selected to really focus on is improving quality measurement. Right now, quality measures with CMS and NCQA focus on the prescription of statins. And what we're hoping to accomplish is to, through a coalition-based approach, achieve improved measurement and management of cholesterol by modifying existing quality measures or scrapping and changing existing quality measures to focus on lipid measurement and LDL control as provided in the most recent versions of the cholesterol guidelines. We've had meetings with CMS and NCQA as of late. Both seem amenable to change, recognizing that there may be some challenge associated with the existing ones. Our target is to see revised measures within the next few years, in the next few cycles. And anybody who's on this call, many of the organizations are already involved in our monthly LDL roundtable to talk about quality measurement, and related projects are invited to join. So if anybody would like to reach out and get involved, please let me know. Thanks, John.
Thank you, Brian. And thank you for your leadership.
Thank you.
Next, we'll hear from one of the National Forum's newest members about the medical fitness model and certified facility standards.
Hello, my name is David Flench. I am the president and CEO of the Medical Fitness Association. So the MFA is a nonprofit professional membership organization that provides industry standards, educational programs, certifications, and networking opportunities to really enhance the operational success and healthcare integration. So a medical fitness center is a medically integrated facility that promotes healthy lifestyle choices as it focuses on the prevention and treatment of lifestyle-related disease, illness, and injury via participation in physical activity, nutrition, chronic disease management programming, and health and wellness education. Medical fitness centers play an essential role in the health and wellness of their communities. So the MFA developed the facility certification program following the publication of the first edition of the MFA Standards and Guidelines. Our certification program is intended to provide a roadmap for facilities so that they can provide safe and effective programs for the people they serve. It also positions a facility as part of the healthcare continuum, establishing a trusted and credible place for healthcare providers to refer their patients with confidence. Several key factors distinguish certified medical fitness centers, including active and regular medical oversight, certified and degreed staff, written policies and procedures concerning user safety and the ability to respond appropriately to all emergencies, disease management and prevention programs, individualized health screening, testing and outcome tracking, and a focus on improving community health. Over the past 15 years, 110 facilities have achieved MFA medical fitness facility certification. These centers have consistently outperformed their peers in nearly all reported outcome data points, both for financial performance and for health measures in their programs. We have our annual conference in a couple of weeks, San Diego, November 4th to 6th. And if anyone would like to attend, please just contact me. I have a few complimentary registrations left. Thank you.
Wow, great offer. David, thank you for the information. Next, we're going to hear about using data and best practices to drive control of LDL, hypertension, and A1C.
Hi there, I'm Hattie Hanley, and I'm showing you, are you able to see my chart in front of you?
We can.
No. You can. Okay, great. So a lot of people are not familiar with our success in driving the law of large numbers community-wide in San Diego. I wanted you to know that by inspiring the health systems with best practices, great food, and great colleagues, convening once a month and teaching using data to drive down LDL to less than 100, blood pressure, and A1C according to the NCQA measures, we were able to drop women's acute myocardial infarction hospitalizations by 25% in 4 years. Community-wide, it was 22%. So that also was associated with 86 million in savings, and it was duplicated in 2 different national publications. So now I'd like to turn to talking about our most recent innovation building on this is that we want to flip the script, driving action with data to prevent atherosclerotic events by deploying the best available tools and evidence. The success and innovation that we're proud to share is shifting from precision population health paralleling cancer screening and staging. We convened experts across 6 of the University of California campuses, plus Stanford, Georgetown, and the Air Force for over a year to create a shared decision-making tool to assist primary care teams. We all know primary care is so overwhelmed. So what we did as a group is we, under the leadership of Dr. David Marin, the head of preventive cardiology at Stanford, the group boiled down the AHA and ACC guidelines, which are literally hundreds of pages, and primary care teams are not going to read them.
10 seconds, Hattie.
Oh, okay. So the work was published as a disease staging system in JACC Advances this last year, and we are so grateful to David Marin and to you for inviting us to speak today.
Well, congratulations. The Right Care Initiative is genuinely a high impact organization, and we are pleased to have you share a couple of examples of your work with us. The graphs speak for themselves. So congratulations and thank you. I want to check back real quickly. I believe Julius Hunter has technical difficulties today and is unable to join us, but I just want to check one more time. Dr. Hunter?
He did drop off.
Okay. So next we're going to hear about your heartbeats for generations.
Good afternoon, John. Thank you. And thank you to the National Forum for having me. My name is Angela Conley, and I am a Hennepin County Commissioner from the great state of Minnesota. Hennepin County, we represent 1.3 million people, and cardiovascular disease is the second largest killer of women specifically in Hennepin County. And after experiencing my own heart attack and surviving it in 2023, I just realized that the symptoms that showed up for me are not the symptoms that I was taught about in school and growing up. So I really wanted to spread the message that symptoms of heart disease and heart attack show up differently for women. And so I authored a board action that invested $1 million into a major marketing campaign and to coordination of care among our clinics within Hennepin County. So what we did was we took out billboards, we were on the sides of buses and talking to residents about, particularly Black and Indigenous women, about how symptoms show up differently, how pain between your shoulder blades, neck pain, pain that radiates along your jaw. These are things I experienced that I never knew were signs of a heart attack. From this work, this is $1 million that is ongoing annually that coordinates care from the time of discharge into support services for women who have experienced heart attacks and to prevent future cardiovascular events. So we're talking about changes to our diet. We have a dedicated webpage, hennepin.us/heartbeats. We are informing folks on how to eat cultural relevant foods by seasoning them differently. We're talking about how lonely it might feel after surviving something as heavy as a heart attack and how to talk to your family about the family history. So we are embarking upon this to save lives, but also through the lens of lived experience. Happy to be a part of this work. Thank you.
Well, Commissioner Conley, thank you very much. It's very exciting work. We're so thankful that you survived your heart attack and that you're channeling the energy from that experience into improving health at the population level. So thank you. And as a former resident of Hennepin County, I'll just say oofta. All right. Thank you all for sharing your impactful work. Dr. Oz said he has hope because there are things we can do to make a difference. Well, you all are making a difference at the national, state, and local levels. And I'm excited because so many of your initiatives are replicable. I mean, libraries in communities all across the country. Look at that opportunity.
Hi, everyone. I am calling the National Forum for Heart Disease and Stroke Prevention's 2025 annual business meeting to order. I'm Bern Melnick, and I have the privilege of serving as chair of this wonderful national forum. I want to give a big dose of vitamin G for gratitude to our terrific CEO, John Clymer, our wonderful staff, and our outstanding board of directors and advisory board. Members will vote today on 3 matters: the approval of our 2024 annual business meeting minutes, the treasurer's report, and the election of directors. Each National Forum member organization has 1 voting representative. Voting today is by poll question on your computer screen. If you are a National Forum voting representative, please vote. There will be 15 seconds to submit your vote on each question. If you have new business to bring before the membership, please use the chat function to bring it to the chair's attention before the call for new business at the end of the meeting. For today's virtual meeting, the Zoom events attendance record will be used instead of a live roll call of members. The The minutes from the October 24th, 24 annual business meeting are in the back pages of the program book. Are there any corrections? If so, please enter them in the chat box. If no corrections are submitted, I need a motion to approve the minutes.
I make a motion to approve the meeting minutes.
I second the motion.
Dr. Phillip has moved the minutes to be approved, and Darwin Labarth seconded the motion. If you are your organization's voting representative, please use the on-screen poll to vote on the motion to approve the October 2024 meeting minutes.
All right, the Zoom poll for this first vote is opening up. Please submit your vote. You'll have about 15 seconds. Closing in about 5 seconds. Thank you, and the poll is closed. Here are the results.
The motion has passed and meeting minutes are approved. Dr. Celeste Phillip, National Forum Treasurer, will now give the corporate operations and finance report.
Thank you, Bern. It's my pleasure to present the 2025 Treasurer's Report. Let's begin with the summary of our checking and savings performance, shown on the first slide. Across our various accounts, we currently hold nearly $1.9 million in total cash and receivables. This represents approximately 16 months of operating expenses, placing us in a strong financial position. Moving to the next slide, the balance sheet comparison for August 2025 highlights how our cash and receivables have changed compared to the prior year, August 2024. As you can see, we are ahead of where we were last year, reflecting continued financial growth and stability. Next, we examine the changes in net assets between 2025 and 2024. There is a notable increase in revenues this year, which has contributed to our improved financial standing. On the following slide, we acknowledge that the National Forum experiences fluctuations in revenues and expenses from month to month and year to year. This is due to the timing of funding, with large amounts arriving in some months and smaller amounts in others, which we often see in most organizations. Despite these fluctuations, the Statement of Activities confirms that the National Forum continues to operate in the black, maintaining a positive financial position. This concludes my report, and I now move to accept the Treasurer's Report as presented. Thank you.
I second the motion.
Dr. Phillip has moved that the Treasurer's Report be approved, and Darwin Labarth seconded the motion. If you are your organization's voting representative, please use the on-screen poll to vote on the motion to approve the Treasurer's Report.
Okay, poll for the vote is opening. Please submit your vote in the next 15 seconds. Votes are flying in, great. Calling for last votes, please. Okay, poll is closed, and here are the results.
The motion carries. The Treasurer's Report is approved. Thank you. Now, John Clymer will give the Executive Director's report.
Dr. Phillip covered the National Forum's financial health in the Treasurer's Report, So this report will focus on the National Forum's future direction. Working together multiplies our collective strength. That is both the function and the strength of the National Forum, founded by the CDC, American Heart Association, and ASTO, to be the hub for collaboration across sectors and disciplines. We gained further strength in the last year with the addition of new members. Welcome to Constellation Quality Health, Heart Charged, and the City of Hometown, Illinois. The Value and Access Collaborative recently released a new co-branded shared decision-making guide on lipoprotein A. You heard Ann Goldberg on the third panel say how widespread high LPA is and that the first ever treatments for it are on the horizon. We will mount a dissemination and implementation campaign into 2026 to help providers and patients use shared decision-making to take advantage of these innovations. The National Forum will continue to provide briefings on timely issues affecting heart, metabolic, and kidney health. Since last year's annual business meeting, we have conducted 11 briefings on a variety of topics. For example, last month, Keith C. Ferdinand, Vice Chair of the AHA-ACC High Blood Pressure Guideline Writing Committee and past Chair of the National Forum, joined our current Chair, Bern Melnick, a member of the Writing Committee, to brief National Forum members on the key actionable takeaways from the new guideline. Representatives of 130 organizations joined the briefing. The briefing met its goal of not just informing, but driving implementation of the guideline. 80% of attendees plan to implement ideas inspired by the meeting, and almost 82% would recommend the event to colleagues. And in July, we held a briefing on dialysis payment changes, a below-the-radar issue that affects treatment access in cardiovascular health. The data indicate that the National Forum's approach to briefings moves the needle on understanding issues. Attendees said the dialysis payment briefing significantly increased their understanding of the issue. In fact, their understanding rose by 45% over the course of the briefing. That increased understanding will enable more stakeholders to add their voices to discussions about the problem with bundled dialysis payment and proposed changes to it. We will continue to expand Move with the Mayor to empower more people in more communities to attain good heart, metabolic, kidney, and mental health. Through Move with the Mayor, we transcend partisanship. We involve Republican, Democratic, and nonpartisan mayors in urban, suburban, and rural communities in strengthening the vital conditions for health and well-being. As this table indicates, we concentrate on advancing policies, programs, and environmental changes that produce a measurable impact. Because the interventions are in the community guide, we can extrapolate their magnitude of impact. A team of board and staff members is intensifying our measurement and reporting on Move with the Mayor's impact. Mayors are great communicators. They're helping us raise awareness of the connections between physical activity and mental health. Listen.
Social connectivity and physical activity are both good for your physical and your mental health. Move with the Mayor is an opportunity to do just that.
When we walk together, talk together, and move together, we're strengthening the fabric of our community. I am super proud that we got involved with Move with the Mayor. This has been invaluable for our community.
Being active in the community helps us to fight off depression. It reduces stress in our lives, and not only physical health, but emotional and mental health as well.
We want our city to be healthy. We want folks to get out, move, and enjoy some of the natural benefits we have.
So we are encouraging you to get up and move. Come outside, get some fresh air, and move your limbs and your body. And join us on this movement.
We have to remain socially active and connected to each other.
Working on your physical health, taking care of your bodies makes a better you, and that's why I love to support Move with the Mayor.
In communities around the U.S., We team up with mayors and local clinicians to urge people to know their LDL cholesterol levels and tell them where they can get tested. We're excited about a new collaboration with the Family Heart Foundation to have mayors and clinicians promote their Cholesterol Connect program, which provides free tests and care navigation. In other communities, we pair mayors with pharmacists to urge people to get immunized against influenza. In addition to adding to the track records of Move with the Mayor and the Value and Access Collaborative, the National Forum has plans to launch the National Lipid Action Collaborative to enable your organization to increase and accelerate its impact on lipid control. Reach more employers with the business case for hypertension control. Document and illuminate model practices for increasing hypertension control, broaden public support for strengthening the vital conditions for health and well-being, ensure the U.S. health deficit does not get bigger as Europe launches its first ever cardiovascular health plan later this year, and stimulate action and collaboration through convenings that change the ecosystem in which we all function. All of these programs align with and advance the National Forum's 25-26 strategic plan, which the board adopted earlier this year. That concludes the Executive Director's report. I will hand the mic back to our chair, Dr. Byrne-Melnick.
John, thank you for that outstanding report. The National Forum is indeed in a strong position financially, and its programs are making a measurable positive impact on health and well-being. The Board of Directors met on October 2nd and elected officers for the next 12 months. The officers will be Celeste Phillip, Vice Chair, Rosie McGillen, Secretary Treasurer, Warren Jones, Past Chair, and I will continue as Chair. Next, we need to elect directors. The board recommends the following slate of candidates for 2-year terms as board members. The Honorable Jerome Adams, who has served 1 term. Meg Guerin Calvert, who also has served 1 term. And Susan Kansagra, who would be a new director.
I move we elect the slate of candidates as recommended.
I second the motion.
Darwin Labarth has moved to elect the slate of candidates. Celeste Phillips seconded the motion. If you are your organization's voting representative, please use the on-screen poll to vote on the motion to elect the nominees presented.
All right, the Zoom poll is opening. Please submit your vote. About 10 seconds. Calling for last votes, please. And thank you. The poll is closed. Here are the results.
Jerome Adams, Meg Guerin Calvert, and Susan Kansagra have been elected. Congratulations. Now we turn to the high point of our business meeting, the presentation of the 2025 National Forum Awards.
Good afternoon. I'm Julie Harville, Director of Operations with the National Forum for Heart Disease and Stroke Prevention. I am joined by my colleagues, Stacy Resendez, Operations Consultant, and Whitney Weber, Communications Manager. Welcome to the National Forum Honors 2025 Awards. The National Forum is proud to recognize individuals and organizations that have made exceptional contributions to preventing heart disease and stroke. While we wish we could celebrate together in person, we are grateful to share this moment virtually. We have received acknowledgments from our award recipients, and we are honored to share their remarks with you today. Since the program began in 2009, the National Forum has presented 102 awards. Today, we are excited to add 8 more to that legacy. National Forum Heart Healthy Stroke Free Award. In recognition of an organization whose work embodies the recommendations of the National Public Health Action Plan to prevent heart disease and stroke.
This year's honoree is Dr. Janet Wright, who recently retired as the Director of the Division for Heart Disease and Stroke Prevention, Centers for Disease Control and Prevention.
For contributing to progress in heart disease and stroke prevention, benefiting people throughout society as a servant leader in the American College of Cardiology, Million Hearts, Office of the Surgeon General, and Centers for Disease Control and Prevention.
It is an honor to accept the Forum's Heart Healthy and Stroke Free Award on behalf of the remarkable individuals and teams and organizations I've been privileged to work alongside over the years. My heartfelt thanks to the National Forum leadership for creating both a place where real collaboration thrives and a roadmap in the Public Health Action Plan. So today and every day, I join you in doing what works everywhere for everyone to build a heart-healthy and stroke-free nation.
National Forum Heart Healthy Stroke Free Award. In recognition of an individual whose work embodies the recommendations of the National Public Health Action Plan to prevent heart disease and stroke.
This year's honoree is Walk with the Doc, accepted by Dr. David Sabger, founding CEO and president.
The founding of Walk with the Doc in 2008 established a sustainable model that promotes walking and learning in a social supportive setting, with over 600 long-standing volunteer-led chapters across varied communities in the U.S. and globally. The initiative increases physical activity, improves health literacy, and fosters community connection, all contributing to improved cardiovascular, metabolic, and mental health.
Our whole team at Walk with a Doc is so grateful to the National Forum for this wonderful Heart Healthy and Stroke Free Award. Our program is built on increasing physical activity, being out in nature, being together, and all improving our education by being with one another. For the National Forum to recognize this means the world to us, to our leaders, our participants, our partners. We cannot thank you enough. Thank you.
National Forum Public Policy Award. In recognition of an individual who has effectively advanced policy change to reduce the national, state, or local heart disease and stroke burden.
This year's honoree is Mark Miodowski, Senior Consultant, Cornerstone Government Affairs.
Over his 4 decades as a public servant and lobbyist, Mark has played a substantive role in securing resources to implement the National Public Health Action Plan to prevent heart disease and stroke. He has guided public health advocates in advancing policies that protect and promote health for everyone, everywhere.
Hi, thank you very much. I am humbled and honored to receive this recognition that has personal meaning for me, having lost both of my parents to congestive heart failure. For the past decades, I've worked alongside the National Forum with many public health organizations at the federal and state level, and the National Forum has accomplished so much during this time, but there's a lot more work to do, and I look forward to supporting the Forum as we tackle the new challenges ahead of us. Thank you again for this award.
National Forum Public Policy Award in recognition of an organization that has effectively advanced policy change to reduce the national, state, or local heart disease and stroke burden.
This year's honoree is the Ripple Foundation, accepted by Becky Payne, President and CEO.
For investing in, developing, and promoting the Vital Conditions for Health and Well-Being framework, making complex determinants of health understandable and actionable, and for advancing measurable systems change that strengthens cardiovascular health across communities and for generations to come.
I'm honored to accept this award from the National Forum on behalf of the staff, trustees, and countless stewards across the country who are working together to improve the vital conditions for health and well-being in their communities every single day. Like you, they recognize the power of this framework to bring people together and compel concerted action so that we can improve the lives and conditions of our fellow Americans. Thank you for your leadership in recognizing us and all that you do to bring a future of thriving together into reality.
National Forum Commitment Award, presented to an individual who has made exceptional contributions to the National Forum. There are 2 National Forum Commitment Awards presented this year.
This first honoree is Meg Gurin-Calvert.
For unwavering dedication, insightful guidance, inspirational leadership, and collaboration that have strengthened the National Forum's impact on cardiovascular health.
Hi, I'm honored and humbled to receive this commitment award. Similarly, I've been honored over the past years to be serving as a National Forum board member and active participant with the opportunity to be involved with other National Forum leadership, and particularly with the staff who bring such great depth and breadth of experience and their commitments to the goals that are emphasized in this statement. I particularly value and am honored to hear the words collaboration and impact on cardiovascular health, because they signify what and how the National Forum and others seek to inspire and accomplish these goals. Emphasizing the impact on health really reflects the idea of commitment to action, investment, and assessment. And for me, it's been wonderful to be part of the collaboration and the activity that looks to see which interventions and actions and by whom and how can really have the greatest benefit for all. So I'm honored again to receive this commitment award and look forward to working collectively with others on those actions for real impact. Thank you again to the National Forum, and let me thank again particularly the National Forum staff.
The second honoree is Derek Jacobs, a recent retiree from the American Heart Association's Washington, D.C. office, where he served as the operations manager.
For collaboration, operational support, and friendship that have helped strengthen the National Forum's impact on cardiovascular health.
Good afternoon. Thank you so much to the National Forum for Heart Disease and Stroke Prevention for this incredible honor. I am deeply humbled and grateful to be standing here today to accept the 2025 Commitment Award. I want to acknowledge and recognize John Clymer, Julie Harville, and their great team who has supported me along the way during my 34-year tenure with the American Heart Association's Advocacy Department. Once again, thank you again for the incredible honor, and I am excited to accept this award.
National Forum Chair Recognition Award. The Chair's Recognition Award recognizes extraordinary service to ensure optimal cardiovascular health and well-being throughout the lifespan. This year, there are 2 awards presented.
The first honoree is Dr. David Joel Marin, C.F. Renberg Professor and Professor of Medicine, Stanford Prevention Research Center.
For uniting experts to develop a coronary artery calcium staging system and practical tools that advance precision prevention and improve shared decision making, and strengthening cardiovascular health through decades of leadership in preventative cardiology.
Thank you, National Forum. I'm honored to receive this award and do so on behalf of the Right Care Initiative and the colleagues I worked with to develop the coronary calcium staging system. I appreciate this recognition for my work in preventive cardiology. I've been at it for more than 40 years, and I've had great mentors and colleagues along the way that have inspired me and for whom I'm very grateful. Thank you again.
The second honoree is Dr. Kate Golick, Clinical Professor, Co-Director of Bachelor of Science in Health and Wellness, The Ohio State University.
For unwavering dedication, insightful guidance, inspirational leadership, and clinical commitment to population health, preventative medicine, clinician well-being, health professional education and wellness, strengthening cardiovascular disease prevention, including Million Hearts.
I would like to extend my sincere gratitude to the National Forum for Heart Disease and Stroke Prevention for this award. I'm very honored and humbled to be the recipient this year. I have been so fortunate to work with both the National Forum and the Million Hearts Initiative over the past 13 years to really make an impact on cardiovascular disease and prevention. Our Million Hearts Fellowship through Ohio State University has had the impact to screen and educate and reach over 115,000 people over the last 13 years. This was not done alone. Many people have contributed to these efforts. So many nurses, so many nursing students, nurse practitioners, nursing faculty, nursing organizations have contributed to this monumental effort to screen and educate our public. I'd also like to recognize Dr. Bernadette Melnick for her vision and leadership over the years. And again, thank you so much to the National Forum for this honor.
Incoming leadership. Board of Directors 2025-2026. Officers. Emeritus Founder. Council. Chief Scientific Advisor. Directors. Federal Liaisons. Advisory Leadership Council. This concludes the 2025 awards ceremony and announcement of the incoming leadership for 2026.
A hearty congratulations to all of our award recipients. Each one of you is moving us closer to the National Forum's vision of people throughout society living and enjoying heart-healthy, stroke-free lives. At this time, the floor is open to new business. New business items can be placed in the chat box. No new business has been submitted. Do I have a motion to adjourn the meeting?
I move to adjourn the meeting.
I second the motion.
The motion has been made and seconded. I will ask for a vote to close the meeting now.
All right, poll is opening for the last vote. Please submit your vote. Calling for last votes, please. And the poll is closed. Here are the final results.
The results are in, and the annual business meeting is adjourned. I'm passing the microphone back to our Executive Director, John Clymer.